Well, okay, things are never dull. Thank you, Rob. Thank you, Jim. We're delighted to start the second round of the COVID and Health conference sponsored by NBER. And I'm especially delighted to introduce David Cutler, who will be talking about motor vehicle accidents. Just in terms of the framework, as you could hear probably, this is being recorded so that we can post it later to live stream for people who couldn't get on this meeting. There will be, if there are co-authors involved during the talk, you should feel free to ask questions in chat. I'll try to come back to some of those, and co-authors should feel free to respond as well. Figure 18 to 20 minute presentation, and we have 30 minutes for each person. So David, the floor is yours. Thank you.
Great, and it's lovely to see everyone again on the second part of our meeting. Let me share my screen, and so the first thing I want to check is, can everyone see the screen? Excellent. Okay, and I'm going to open the chat. It's actually just me on this, so I will not be responding to comments during the talk, but I will try and save a copy of them. So this is a paper. It's sort of an unusual paper in that every day that I work on the paper, the number of data points grows. So I've sort of rarely had a situation like that. It's about a topic on motor vehicle fatalities in the COVID recession. Let me sort of explain kind of the genesis of this, because it's not sort of the usual type of thing I work on. So since Chris Room's work now a couple of decades ago, it's been one of the truisms of health economics has been that mortality falls in recessions. And at least one of the big reasons why that's the case is because motor vehicle fatalities fall in recessions. Now, actually, just to set terms for a second, motor vehicle fatalities involve two things. One is it involves occupants to the cars, the driver and the passengers. And second, it involves non-occupants, pedestrians who may get hit by a car. So that's included there as well. So that was all fine, and I'm taking that as given. And then over the spring and into the summer, there were a bunch of reports like what I've shown you here about, people are driving faster on roads, and the number of automobile accidents at very high speeds is going up, and motor vehicle fatalities continue to rise, and so on. So that sort of led me to think in my mind about the question of, is this current recession or the impact of COVID sort of having a different impact on motor vehicle fatalities than in the past, and if so, why? And so that's what I want to talk about. This paper is not done. So what happened was it was sort of bubbling over in my mind. As you know, we sort of, the NIA has been pushing us to think about the impact of COVID on the economy. And so in light of that, I said, well, why don't I try and take a little piece of this and just try and see what's going on. So there are two sorts of things. One is sort of, is it different? That is, are those headlines, are those anecdotal headlines actually data? That is there a different trend in motor vehicle fatalities now than one would have guessed? And the answer to that is very clearly yes, as I'll show you in just a couple of minutes. And so that part I'll have pretty certain. The second part is a little bit more difficult, which is, why is that? And there are at least a couple of different hypotheses, and I'll look at one of them today, and I'll come back to some of the others later on. But the two sort of basic hypotheses that you can think of, there are probably more. One is that speed increases have offset the value of fewer cars on the road. So you can think about this as a little bit like a model where, what people do is they hold constant the probability of being in a serious accident. So if there are fewer cars, I'm going to drive faster, and that will then offset the reduction in the chance of hitting in the number of people to hit. The second one is that and this is one I'll be able to look at more today, which is that different driving has different amounts of fatality probability associated with it. So driving slowly on a local road is not particularly high on the fatality list, whereas riding your motorcycle on the interstate is. And so some of what may have happened is a reduction in the kind of safe driving and less of a reduction in the unsafe driving. For example, unsafe driving includes an accident with a truck on an interstate. And if you say, well, now everybody's at home, so we're having more trucks bring things to people, then you may not have had a big reduction in the risk of an accident should one occur. So I'll try and look at things like characteristics of who's driving to see how that's changed during the recession. Just a little bit going from the anecdotes first to the to a little bit more in the data. I've sort of tried to get a sense, and I'll know much more about this for some states, but I've tried to get a sense about, are people really speeding a lot more? So this is data from Alabama on what percentage of the speeding tickets given out are at very high speed. So you can see 1 to 20 miles above the speed limit, 20 to 35, 35 to 50, and then greater than 50. So the share of tickets that are over 35 miles per hour above the speed limit has gone up quite a lot in 2020 relative to 2019. If you look at Montana, I just sort of tried to Google around and see where I could get data. If you look at Montana, the average speed of over the speed limit for tickets has gone up quite a lot. If you look at Minnesota, the share of tickets at very high levels have gone up a lot. This is so it's very clear that there are more people who are speeding. Of course, there are more people who are getting a ticket for very high levels of speeding. Unclear whether that's more speeding or whether the police are not pulling people over if they're only going 5 miles per hour above the speed limit, either because it's deemed to be safer, because they don't want to be interacting with people as much. So this is just a sort of little bit of information. So what I want to do first, and this is the part I think, as I say, I can be somewhat more convincing on, is there a different relationship between motor vehicle fatalities and the economy now than there has been for some period of time? So I want to do that. Chris Room in his work, of course, used sort of state level data over time. I actually don't want to set up the panel that way. I want to look at the aggregate data, and I just want to show you about some of the aggregate data. The state level data I'll show you a little bit about is basically going to give you the exact same finding. But so what I'm going to do, what I did was I took long-term data on motor vehicle fatalities per person. And then I just want to sort of set up a prediction model for what should have happened if 2020 looked like previous years. So I'm going to estimate the model. I've got monthly data. So I'm going to estimate the model of deaths per person on the unemployment rate. So that's the key economic measure. The relative price of gasoline, which is going to influence how much people drive. Time trends, and then I'm going to take out monthly effects because they're huge monthly effects in how much people drive and fatalities of driving and so on. And so I'm going to estimate that through 2019, and then I'm going to compare it through 2020. The reason why I'm not so concerned about the exact specification here is you're just going to see that the outliers in 2020 are just immense. So there's like almost nothing that the specification that you could plausibly think of the specification as doing that would affect this. The data come from various different reports supplied by states that are collected and put together. So let me show you first just kind of a picture of, is 2020 different? So what you're seeing here is the trend in motor vehicle deaths per 100,000 people. And that's a number that's gone down over time. In fact, if I'd gone back further, it would have gone down even more. So very big reductions in motor vehicle deaths. They go down a lot. The shaded areas are recessions. I haven't yet shown you COVID, so I've left off the last few data points, which I'll show you in just a second. So this is showing you that you can fit the model pretty well. So in recessions, so the key point you want to take from this is that in recessions, deaths fall, and this is exactly Chris Room's point. So this is not at all anything new that I'm telling you here. If you then look at the prediction for 2020, and I'll show you this in a little more detail on the next slide, the prediction, given what happened to unemployment, is this red line, which is a massive decrease in deaths per capita. What we got was this blue line, which is a massive increase in deaths per capita. And so let me show you this here. This is just showing you how well the model fits from 2019 and 2020. So the model fits very well in 2019. And then if you look at what happened in 2020, you can see the prediction goes way down. So it should have fallen by, roughly 20 or 30%. And in fact, aside from deaths falling in the month of April, in every other month, actually motor vehicle deaths have gone up relative to the past. So, and the volume of traffic on roads has gone down enormously, but the deaths have actually gone up, again, with the exception of the 1 month. This is March, where half the month was sort of closed down, April and so on. when people look at this, they tend to look at divide this into two things. One is what's happened to driving, that is how many miles are people driving, and then second is what's happening to the fatality rate associated with each mile driven. And those may differentially be influenced by recessions. So I just want to do that a little bit here to show you. So this is what's happening to miles driven. You can see that, again, that if you look at the red line, miles driven fall in typical recessions. So if you were to relate this to the unemployment rate, you'd clearly see a negative impact of motor vehicles miles driven per capita. You would have expected, given the increase in unemployment rates, you would have expected some reduction in miles driven. In fact, it was a much greater reduction in miles driven than one would have guessed. I think in part that's because many of us, like us, don't have to drive anywhere, but we're not unemployed. So when you had to go to a job, it was sort of, there was some amount of driving that had to happen. And I think some of what this is picking up is the people who don't need to drive, but can still work. And so the unemployment rate it didn't go up by as much relative to the miles fallen. That then means, and this is the other part here, that then means that deaths per mile driven have increased enormously. So again, you would have guessed in a recession that in a typical recession, deaths per mile actually fall. And here they've just astronomically shot up by roughly the equivalent of 20 years worth of progress in deaths per mile. So this sort of recession has basically erased about what the last 20 years or so of 20 to 30 years of progress would be. One other thing I was sort of interested in, I see that Frank has a comment about the geographic component, which I've done a little bit on, and I want to do somewhat more. Angus, sorry. In response to Angus's question, all those pictures I took out. I seasonally adjusted them, so I took out all the monthly effects. Otherwise, it would just be dominate. It would just look like a jagged line. I wanted to get rid of those. So I did a little bit of poking around about what's going on. So this is just the change in the number of motor vehicle deaths for the period April through October of 2020 relative to April through October of 2019. And this is the change in vehicle miles traveled over the same period of time. So first thing you can see is that everywhere has had a massive reduction in vehicle miles traveled. So a mean would be about 20% reduction in 20% log scale vehicle miles traveled. And then you can see the increase in motor vehicle or change in motor vehicle deaths. In a couple of states, it's gone down. John Skinner, New Hampshire is the big winner here. Massachusetts, I'm going to show you more data about in just a little bit. So Massachusetts is just about zero, very slight decline. And then you can see some increases. Many of these are very small states. The red line here is the weighted regression line. So there's a very slight but non-significant relationship between these. So it doesn't look like there's anything, it looks like these are basically dissociated from each other, which really surprised me some. This is total deaths. What that means is that in areas where miles traveled fell by more, deaths per mile rose by more. So that these states had higher increases in fatalities per mile driven than did these areas over here. Just to give you a sense of what we're looking at relative to this is kind of the Great Recession, and the Great Recession reduced miles driven by a couple of percent. So these are far, far greater than anything in the Great Recession. One of the questions which I haven't done enough on yet is why is this different than the Great Recession? And part of my hypothesis, maybe these declines were so big that you get a different response when the roads are really clear versus only slightly clearer. So maybe there's a nonlinear response. I have not looked at that at all, but I'm gearing up to try and do that. If your favorite measure of recessions is unemployment, this is showing you the change in the unemployment rate and motor vehicle deaths. Again, there's basically no relationship. It is the case, that this line is downward sloping, kind of like the Chris Room fact would give you, which is that higher unemployment is slightly lower deaths, but in fact, everywhere it's above zero, it's never below zero, and it's not a statistically significant negative line. So I'm basically just going to take this as sort of that these two are unrelated, and at least my first pass is that these two are unrelated. Okay, so that then sort of leads me into the second part of this, which is why did deaths per mile increase so much. And so the model that I have sort of loosely here is that someone makes a driving decision, that is they want to drive or they have to drive for work. And then there are a few characteristics that influence the accident probability. They typically get divided into three groups. There's human characteristics, of which one of the ones here is speed. So that's obviously the one that I'm going to focus on more. But there are things like drug and alcohol use, safety belt use, and so on. A little bit less clear why those should respond, although as Frank Sloan notes, there were changes in the ability to access bars over this time period. So that's something that I'm going to try and look at as well. Their vehicle characteristics, what type of car it is, and then their environmental characteristics, the weather, and is there road glare and things like that. Those all influence whether there's an accident, and then sometimes the accident is fatal. So what I want to think about here is how much of what's happening in terms of more deaths per mile driven is changes in who's on the road. That is, maybe it's still high-risk vehicles that are on the road, and changes in the driving behavior, and in particular speed, although I'm happy to include the others as well, that might influence both the accident probability and the probability that have it conditional on an accident, that it turns out to be a fatal accident. So that's what I want to try and look at. The national data don't have anything on the number of accidents over time. So nor do you, so you don't know, like, for example, how many non-fatal accidents there are and of what types they are and so on. So I can't actually do the second part nationally the way that I'd like to. So what I'm going to do, and I've got some of it here and more of it's going to be coming, I'm basically assembling a ton of information from one state that does have a lot of this, which is Massachusetts. So Massachusetts has public records of all the automobile accidents. So any accident is supposed to be reported if it involves physical injury or property damage in an amount of $1,000 or more. Either an individual or police officer can file it, and then it would be verified by the police, who then file a report. This is typically done for both liability reasons and for insurance reasons. So there's a sort of reason this would want to be accurate. Massachusetts also has actually very good data, which I'm in the process of sort of downloading and assembling and all, on vehicle miles driven on each road. So there are a bunch of stations. So the way you get vehicle miles driven is there are a bunch of stations. So there's different stations on a bunch of different roads. They measure the number of cars going by, so you can get volumes and you can get speeds because they measure speeds of cars. So the Department of Transportation keeps a lot of that data. So let me show you a little bit. So first thing I want to show you is, well, are there, maybe what's happened to the number of automobile accidents, right? So when I showed you the chart earlier on automobile accidents, which are on automobile deaths and vehicle miles driven, the sort of hypothesis is with fewer vehicle miles driven, there should be fewer accidents. So what I want to show you here is what's happened over time to the number of accidents, and both any accident and then fatal accidents. So this is a little bit of a busy chart. The blue line here is vehicle miles traveled. So you can see vehicle miles traveled is generally pretty flat, a little bit declining early in 2020. And then of course it falls enormously. It falls by about 40% in Massachusetts before recovering close to where it was in the beginning of 2019, below where you would have guessed it would be since vehicle miles traveled tend to increase during the year. The orange line is any crash. So any crash with reasonable property damage and so on. And that's actually gone down by even more. So the number of crashes has gone down by roughly the same amount, if anything, a little bit greater than the vehicle miles driven. What has not changed at all is the number of fatal crashes. And in this case, what I'm showing you is crashes involving an occupant fatality, so not a pedestrian fatality. So because I want to get away from who's outside and on the street and stuff like that. And as we're talking about, that's the thing that's actually increased. So there's basically been this sort of big divergence in that there are fewer accidents, but the ones that are occurring are much more likely to be fatal. I tried doing, so I can, this data go back, and I've got the data going back and stuff. This is the data from the Great Recession. I haven't yet sort of estimated the full time series model yet. One of the things, so this is the black line here is the dating of the Great Recession, so pre and post the Great Recession. And you can see sort of relative to what was a flat trend, particularly in 2009, when the unemployment rate is at its peak. I think, Jim, is that the peak unemployment, 2009 or 10? Vehicle miles crashes are definitely lower in 2009, 10 than they were prior to that. So that's different. That's the same as the what I was just showing you for the COVID recession. And, you know, I'll do this a little bit more formally, but it kind of looks like, with a couple of exceptions, that fatal crashes are down as well in the Great Recession. Whereas not quite as much as the overall crashes, but that clearly looks different here. There's like a huge difference, and you're not seeing a gap. You're seeing a little bit of a gap, but a much smaller gap between the two in this figure than in the previous figure. So that's, I think, part of the difference is that this recession is sort of uniquely different in terms of the crashes that are happening are more likely to be fatal. Let me just show you a little bit about what types of things are becoming more fatal and what's going on. So I want to see how high-risk driving has changed. So I need to define high-risk driving. So I can tell, since I have data on every crash and I know if it was fatal, I can estimate the probability that any particular crash is fatal using a bunch of characteristics. And then I can predict whether that crash would have been fatal or not. And then I can see, I'm going to leave speed out of this because I don't really know speed for them all. And then I can see whether the actual fatality associated with crashes, which ones got more fatal, and is that plausibly because speed will have gone up. So let me just show you a little bit about the fatality risk. So I have a bunch of things that I can look at: characteristics of the vehicle, is it a motorcycle, a car, a truck, and so on, the type of collision, the time in the day, what type of road, all sorts of stuff like that. Just to show you where people die, so there are two types of basic ways. One is you're in a car and the car is in somewhere driving fast, in interstate or what are these sort of big highways. So that's the first way you die. The second way is you're a pedestrian and you're either crossing a very busy non-interstate, or you're like in a parking lot and you get hit by a car and then you get killed from that. If you look at the predicted risk, it's actually extremely spread. So it's almost all crashes involve very little fatality risk, with the exception that a few involve higher, where higher is 2%. So 2% of these crashes will turn out to be fatal. I'm going to divide them into kind of very low risk, medium risk, and high risk. And what I show you here is what is happening to the number of crashes by risk status. And you can see that actually the highest risk crashes decline by less. So part of what's going on in 2020 is that the miles driven are actually declining more in the miles that are not likely to be fatal. And so this is some of it. I haven't yet compared this to the Great Recession, but that's one of my questions, is whether this is different. So at least part of it is we shouldn't be quite so surprised, because the cars and the trucks that are most likely to have fatal accidents are still on the road, at least they haven't gone off the road as much. Even conditional on that, though, high risk accidents are more likely to be fatal than they used to be. So if you take the highest risk accidents, the probability that they result in death to an occupant has gone up. So there's some composition change, but there's still some effect, which is that the same accident is more likely to be fatal. And that's perhaps because of speed. And as I said, I'm in the process of matching this up with data on speeds on the roadways where people are going and how many cars were traveling there. So I can look a little bit more carefully at, is it the case that in roads that became vastly depopulated by cars, people just sped up more, and therefore crashes when they occurred become more fatal? And is that what's going on here? So that's where I am at the moment. Let me stop here and kind of open it up. I saw a bunch of notes going by, which I didn't follow all of, but I'll let John Skinner take over.
This is great. Thank you. Really interesting. And if anybody can explain why Vermont's at the top and New Hampshire's at the bottom, it seems like, I mean, we even share a school district with Vermont, so it's sort of curious. If it's okay, let me read. One question was, sort of Janet Curry started off a thread, and if you want to jump in and ask yourself, but it was basically about, like, are there different people driving? People who aren't in school? Are they, who are the people, the riskiness of people who still drive? Is the people who ignore the stay-at-home things, are they inherently different and like crazy drivers?
Yeah, so that's on the, that's some of this issue on the composition of the cars. So I know less about who's driving than I do about who is involved in an accident. So I will be able to look and see about that. I don't, so, so for example, I can look at, for what is the rate of accidents among, say, teen drivers, or the rate of accidents among, different types of drivers. So and those are a little bit wrapped up in that kind of composition thing that I showed you, because those are all associated with the fatality probability. But what I don't have data on is kind of how many people are just on the road of different characteristics. So like, I don't know, out of everyone on the road in April, what share of the drivers are younger or older or, more likely to be whatever. I will know about the types of cars, about what class of cars they are, but I won't know about other characteristics.
So I just want to jump in and share an anecdote quickly, which is where my comment was coming from, which is that this spring in New York City, there were people drag racing down major thoroughfares, including, we have an apartment on Riverside Drive. There was drag racing like all night on Riverside Drive. You couldn't sleep. And there was spectacular footage of crashes being shared on Twitter, where people were going to and lost control of their vehicles, hit parked cars, went through store windows, and so on. So you could definitely motivate some of this with that. And the thing is that just never happens during a regular recession. And I think it was also compounded by the fact that for a while, the police kind of pulled back giving anybody a ticket. So, because of all the other events that were going on. So there were a number of very unique features of this.
And one of the things, I'm sorry to interrupt. One of the things, Janet, that your comment suggested is that there could be a nonlinearity here. That is that if the roads get really clear, then you have a very big increase in deaths because people will drive a whole lot faster. Whereas what you'd normally think about here, your first thought to think about here is, oh, okay, I'm not stuck in rush hour traffic. It's hard to kill yourself in rush hour traffic because you're not going fast enough. But now if rush hour has got fewer cars, I get to drive a little bit faster during rush hour. And the key is that may not be enough because you still may not be able to drive fast enough to do real serious damage. Whereas when the road is virtually empty, maybe you can do a lot. So I really want to look at a lot of those nonlinearities here and try and understand why this recession may be different. And it's potentially a kind of nonlinear situation like that. But if you have good video, I'd love to have it because it would be a great way to start the.
We can demo it for you. So Angus asked about male-female differences.
Yeah, so I know I know everything about the crash. I know lots of stuff about the occupants, but I don't know is who's on the road. Mm. So if you're not in a crash, I don't know about the driver who's on the road. What I will know are things like how many cars went through a certain area where they have information, like on, I-95 somewhere. I'll know how many cars went by there, but I won't know anything about the driver unless they were in a crash. But I absolutely can say what's going on with the the distribution. How many crashes are there for drivers of particular types, and that is what's in this chart. Here is the sort of, these are the high risk accidents, which are down, but not nearly as much as the lower risk accidents.
So there are lots of questions. You definitely engaged the group. The questions about more data. Can you get Easy Pass data? Can you get cell phone data? Any prospects there?
So the data on volumes of cars, I can get. One of the nice things about Massachusetts is there are all these stations on the road, so I can get them from those stations on the roads. They're more than just Easy Pass because they do them not just on highways, and the Easy Passes are not so frequent, and they're not on all the highways. So I can get data on the number of cars, the volume by hour, by day, for quite a number of stations in Massachusetts. That I can get very well. I haven't investigated closely. I think you've used some of this safe graph data, so you may have a sense as to whether one could get data on, by type of person on whether it looks like people are driving. I don't know the answer, so I should look into that, and maybe if Cosley knows the answer, that's great. And if not, I'll try and find it out, or anyone else too.
I don't think it's I don't know of a product that exists, but I'm looking into it, whether there is a possibility of them creating it.
Thank you.
This is great. There are other great questions here too, also about DUIs and things. I guess you could pick up some of those.
Yep. Yep. I can also get, you can also get, I've got data from Massachusetts, which I didn't show you, on DUI stuff. There's a little bit of national data on that. So I've got a lot of stuff on that. I took from I should clearly do more on the state stuff, but I took from that there's unlikely to be a lot of good hunting in that, good fishing in that pond, but I should clearly do some more.
Great. Thank you so much, David. This was terrific. Right. Our next talk will be, I guess, Enge will be speaking on effect of state COVID-19 closure policy on non-COVID-19 healthcare utilization and health. So
thank you. I think you struggled a little bit with my name, so it's Enge Ziden.
Oh, Enge. Okay, thank you.
It's a cool name from Egypt. My parents were cool kids in the 90s. Okay, so let me share my screen. And can you guys see my screen?
Yes.
Okay. All right, so this is work on non-COVID-19 care with Cosley Simon and Cody Wing from Indiana University. Let me just start out by saying that in March 2020, we started fighting a global pandemic. In fighting this pandemic, we have employed mainly two things: public policy and medical innovation. I think we're all waiting on that vaccine. An unintended consequence of our efforts in fighting the pandemic has been that life stopped. Life entirely stopped in March 2020 and April. One thing we've seen is a decrease in non-COVID-19 healthcare utilization. This presented both a problem and an opportunity. The problem was we were all concerned, and we're still concerned, about what is happening to the health of these individuals that are potentially delaying or deferring care. The opportunity, however, is that we may be able to estimate or study the value of medical care by looking at individuals who delayed or deferred care and then examining their health downstream. So while it's sad what is going on, there may be some benefit for us as researchers. So what am I going to do today? I'm going to do three things. One, the boring bit. I'm going to show you trends in healthcare utilization over time for the past few months. You'll see the infamous dip and rebound of multiple services. And then I'm going to try and think a little bit about what services are beneficial and what services are less valuable. And I'll say valuable very sheepishly because I still haven't had my head wrapped around it. But I'll show you some trends by comorbidities and by patients. Then I'll ask, have the state policies really affected the decrease in healthcare utilization, or has it been private choices? And I'll maybe give some examples from past disease outbreaks that signal that this is not unique to the COVID-19 pandemic, although the magnitude for sure is unique. The final thing I'll do today is I'll take a stab at trying to think about estimating the downstream health effects for those who had deferred or delayed care. And I'll do this really simply in two approaches. The first approach is I'll just do a natural history study where I'll follow people over time and see what happened to them. The other approach is a little bit more complicated, and I'll talk about it in a little bit. So there's been a lot of work already on trends in decreases in non-COVID-19 care. In fact, electronic medical record systems have been generating their own reports to show us decreases in non-COVID-19 care. This is not unique to COVID-19. So I recently read a study on MERS in South Korea, which had 186 cases of MERS in 2015. And South Korea did this really cute thing where they published the names of the hospitals that have COVID-19 patients in the newspaper. And so people stopped going to the hospitals that were published in the newspaper. We've seen this also in past examples like Ebola in Africa, where women would avoid delivery in hospitals during peak the Ebola time. And even in the United States, with the misunderstanding of how contagious or the disease spread of AIDS in the 1980s. Okay. So first bit is changes in utilization. Here, I'm going to start by saying it's really unclear what the consequences of this delayed or deferred care are going to be, and what care should and shouldn't be delayed. So if you think about value, high versus low value, you may be thinking about the marginal benefit of a service. But here, we're wanting to also think about delayed care, so non-delayable or non-deferable and deferrable care, and they're not the same thing. So while preventative care may be of high value, it may also be the type of care that's deferrable. Maybe some care that's non-deferrable is care with symptoms and not asymptomatic care. So I'll try to think about this in more detail as we go on. Okay, and then we'll, before I show you any of the trends, I just want to tell you that we've worked with the COVID-19 research database, and they've given us access to electronic medical records, which I'll describe in a little bit, from a company called HealthJump. We have prescription drug records from Symphony and mobility data from PlaceIQ. So the electronic medical records that I'll show the data from today, because it's a new company and not a lot of people have worked with it. It's a data integration company. So what happens is electronic medical records like Cerner and Epic transmit their data to HealthJump to homogenize the data for them. HealthJump then remits the data to us on a weekly basis. So we are getting weekly updates of this data. To be completely honest, when I was writing this slide, I thought, oh, let me highlight why electronic medical records may be the best thing to do for this research, because they include vitals and labs and lab values. But to be completely honest with you, beggars cannot be choosers. And when we started this research in June, we didn't even think that there was going to be healthcare data available for us to track the pandemic in real time. I think this has been the most unique thing about this disease outbreak, is the availability of data in real time. Okay, so we have about 38 million people who are registered in this electronic medical record integration platform. They come from different EMR systems. We are worried a little bit about sample attrition. I'll discuss this in a little bit. So what we do is we only study people that we know had visits in 2019 and 2020, a sample of 5 million or 6 million unique individuals, just so we don't have to worry about who's leaving the EMR system. Okay, in the future, we are linking the EMR data with other data, and I'm happy to answer questions about that post-presentation. Okay. We also have prescription drug claims from Symphony. This is a well-known data set. And then we have state policies from a great effort by the Urban Institute, some of our own data collection, and then mobility data from PlaceIQ. All right, let's get to business. So what are we showing? Outpatient visits decreased. Okay, I'm not sure why my slides stopped moving. Do we know why? Okay. All right.
There you go.
Yeah, it's just, okay. So there was a 30% decrease over the minimum point, the worst, which was the end of March, early April, and then a rebound in, this is outpatient total visits. So you can see it rebounds back. This is data until week 40, of 2020, which is the end of September. If you overlay mobility, like the Dex Place IQ mobility, on top of this chart, you will not be surprised. You will see that mobility and outpatient visits track pretty well. The world stops, people stop going out, people stop driving, but they also stop going to the doctor. Look at inpatient visits, you'll see about a 40% decrease in inpatient visits. Again, I think other people have published these numbers. It's rebounded some, but remains about 10% below its baseline value, and definitely below 2019, even until October. So this inpatient claims is until October 30th, and it's complete. I have removed the COVID-19 admissions, and I've removed motor vehicle accidents after looking at the presentation schedule and some of the papers on there. Now, if you overlay mobility onto the inpatient admissions, you see something also perplexing. I overlaid infarctions like heart attacks and strokes, and they mimic the mobility pattern. And so I sat there for a little bit thinking it may be that people are afraid to go to the hospital. It may be that they're being harvested by COVID-19. So if I overlaid death from COVID-19 for people likely to have a heart attack or a stroke, maybe I'll find an uptick. It could be also a reduction in stress levels. So I did the unscientific thing, and I called my father-in-law in the United Kingdom, who doesn't have one stroke, but two. So he's a man of experience. And I asked him, how come strokes decrease as soon as mobility decreases? And his hypothesis is that it's the reduction in stress, the stress of driving, for example. So this is definitely something perplexing. All right, so now I'll show you some policy effects. And what does that mean? What I'm interested in is I'm interested in understanding, did these reductions in visits occur because we suspended elective procedures, or is it private choices of individuals? One way to do this is to just maybe do event study plots, simple things, using the stay-at-home orders, the elective suspensions, and then first case and first death. So first case and first death here are really proxying for fear of disease. So this is the first announced death, first announced case, suspension of elective procedures, and earliest of stay-at-home or business closure. And we will see this throughout the presentation, that predominantly the only thing that matters is the first case and the first death, and not the suspension, the explicit suspension of the procedures, or even the stay-at-home orders. For example, mobility decreased in almost all states in the United States, including the 7 that never mentioned the word stay-at-home. Okay, so now I want to think about types of care. So were there heterogeneous responses in how care was delayed or deferred? Were individual actions really relaying what we would think is beneficial care versus less valuable care? And here it's treacherous. So one way to do this is to think about low value care. So what's low value care? The literature gives us some examples from clinical treatments that are known to be undesirable for certain diagnoses. So CT scans for sinusitis, head imaging for uncomplicated headaches, and so on. So things that are not medically thought to be valuable, low value. And then high value care, I create some groups. One group I create is preventative care, but not any preventative care with a diagnosis or a justification. So mammograms for women above a certain age, lung cancer screening for men with history of smoking, which I can identify in the medical, electronic medical records, cholesterol screening for men and women who have a BMI above 30. So I create these cohorts and then I examine them. Okay. The most important thing to realize is that high and low value doesn't mean it should be deferred or not deferred. So think of something like preventative care. Preventative care is remedying something that's asymptomatic, and so may be thought to be deferrable. There's also another layer of complication, which is that care that could be most valuable because a patient is comorbid is also care that may be most risky because the comorbidities in themselves are correlated with the infection to fatality rate from COVID-19. And so while I may be, really benefiting from that marginal doctor visit, it's also the one where the marginal cost has increased since the COVID-19 pandemic because of the infection to fatality rate. Okay. So this is preventative care with a diagnosis. I see that I list some examples here. It decreases to about by 30% and then it rebounds. I'll move on. You can see that the response is really after the first case, the decrease starts to happen. Nothing from the elective procedures being suspended, although most of these preventative services are not just E&M visits, they are blood tests and they are scans. This group is diabetes management care. It's a hodgepodge of everything diabetics get, from blood screens to foot exams to full risk assessments. And here it dips up to 40% and then picks up again to predominantly back to pre-pandemic levels. Okay. Again, response to the first case. This is something that's low value. Just based on the definition. So I put here the clinically inappropriate care. So sinusitis, undefined causes, and then plus a head scan for that patient. Low back pain, unidentified, and back imaging for that patient. Okay, so here we see it decreases by 50%, but it doesn't go back to pre-pandemic levels. All right, and here we see that it responds to the first death. I'm not keeping an eye on the chat, so if it's blanking, it's not because I'm blanking you, it's just because I will get really flustered. Okay, so now I'm going to try and do this by patient groups. So what I'm going to do is I'm going to define groups of individuals that have comorbidities in 2019. Take the diabetics, the hypertensive patients, the chronic circulatory disease, the cancers, and follow them over time to see what happens to their visits. I'm not going to show all the plots here, but one interesting thing is that if you look within a disease group by disease burden, you may find interesting trends. So here, the first chart on the left is chronic circulatory disease, a very big group of patients in the United States. And within them, I've defined them the way CMS defines them, as multiple comorbidities or a single comorbidity. So are you a CCD patient with obesity as well, or no obesity, and so on. And you can see that the group with no other comorbidities decreases less than the group with comorbidities and rebounds to normal levels faster. We see less of that in diabetes, but this just goes to show, my point here is that if we think that the marginal benefit of care for a group is high and that group shouldn't be deferring care, we should also be thinking about the marginal cost, because the marginal cost is really going to impede the return as long as the COVID cases are high, since the infection to fatality rate is correlated with comorbidities as well. Okay. Now we can step back as well and think about other inputs in the health production function. So doctor visits are not the only medical input. There's also pharmaceutical interventions, prescription drugs. And we have seen early evidence of increases in prescription drug day supply. This is to be expected. The marginal cost of prescription drugs is actually really low. 86% of prescription drugs are electronically prescribed in the US pre-pandemic. Companies have now moved to zero delivery like CVS, and insurers have been encouraging practitioners to give 90-day supply. So when we think about the downstream health effects, we have to also realize that there are substitutes, and the marginal cost of these substitutes is changing. So here I plot some prescription drug day supply from Symphony. This is 92% of all commercial prescription drugs in the United States. And I did 3 big groups. I did insulin, I did oral chemotherapy, and beta blockers and statins together. And one thing you see for sure is increases in the day supply, specifically for oral chemotherapy. It's really unclear here. I haven't done much work, and I want to do more here as to whether this is a substitution from infusion therapy that was given in the hospital towards oral therapy, or just increases in doses. But there may be changes in modality as well that's occurring here. Okay, so now we get to the interesting bit, the downstream health effects. When I started this, I had two ways of going forward. The first way is really simple. Just pin down or flag a patient that has a specific comorbidity in 2019, find out what happened to their outpatient visits. Oh, we see their outpatient visits have decreased. And find out what you see for inpatient visits. You see inpatient visits suddenly surge after the reopening. So this is a downstream effect of missing a doctor's visit. So I do this for a few cohorts. I define diabetics, CCDs, chronic kidney disease, hypertension, and we track them down. We're still working on this. So what we would like to ultimately be able to do is track down their lab values by seeing their baseline lab values and their 2020 onward lab values. So, but today I'll show you their inpatient care. So this is the share admitted as an inpatient for these cohorts. The left-hand side has everyone except the chronic kidney disease because they get a lot more admissions than everyone else. So they're not on an axis by themselves. So if you look at the diabetes cohort, 2 in 1,000 would get hospitalized in a given month from the cohort that I identified in 2019. You see their inpatient admissions decrease as you expect with everything else that happened in the pandemic. But then we don't actually see until October 30th any pickup in inpatient admissions. So this is the first kind of descriptive finding, is that I'm not seeing surges in inpatient claims in later months, but we are still in it. We are still in the pandemic. Okay. The second approach is a little bit different. So I realized in the electronic medical records that you can actually identify a visit that was scheduled but missed, delayed, or rescheduled, because you will not find it in the billing and you will not find any notes from the doctor on that visit, which means this visit was missed. So what I did is I subtracted the visits that were actually realized or attended from the visits scheduled. Now I have potentially a cohort that had visits scheduled in February and a cohort that had visits scheduled in March. And the only kind of difference between them is the cohort in March had to bear a healthcare hiatus that happened due to the pandemic. So my assumption here, the subtle assumption, is that between scheduling and attendance of a visit, there is some lag. And so we should be able to see a surge in missed visits in the period of March, April, and then a decrease later. If I take these two cohorts, these adjacent cohorts, and that's kind of what I'm thinking about doing, and then follow them over time and find out the share that was admitted as an inpatient 60 days or 90 days post missing a visit, I may be able to study the value of the visit itself. Okay. So here's the share of missed or delayed outpatient appointments and the number. So in 2019, about 12% of visits, 12 to 14% are missed or delayed. I should note that if you went and saw another provider that week, you didn't go to, let's say, Dr. Ziden, then I don't classify you in this data. You haven't missed a visit. If you didn't come to your outpatient visit because you went to the hospital to be admitted or to the ER, I don't count you in this data either. So I make some assumptions, but approximately 12% of appointments are rescheduled or delayed. And then this surges to 22% in the period of March, April. So it goes from just 500,000 appointments to 1 million appointments that were missed. Okay. Now, another point to note here is that the share of missed visits really decreases in August, September, and October 2020. There's definitely changes in the composition of who is missing visits past April, because there's also changes in who is scheduling visits past April. So we really just want to focus on the March April 2020 cohort. Okay. So now I take these people and I stack their inpatient admissions and I look at the share of individuals who are hospitalized 60 and 90 days post missing a visit. I compare them to 2019 because there are seasonality issues to keep in mind. So almost all patients who miss a visit, the share of them that's admitted to inpatient is lower in 2020 than in 2019. You can see the dip in 2020 around the March-April period, and that's really just coming from the total inpatient decreases overall. But perhaps what's most interesting is that the people who missed visits in August, this is the end of the chart, 60 days later, about 1.5 in 1,000 have been hospitalized. And that number is not higher than any other number in 2020, and it's definitely not higher than the 2019 levels. So if it was higher, I'd see like a surge at 3 in 1,000 or 2 in 1,000 have been hospitalized after missing a visit. So I do this for 60 days and 90 days. I'd love to do it for longer, but you know, we are in the near future still. Okay.
This is great. Wrap, maybe time to, perfect.
Okay.
Wrapping
Great.
up.
So I'm done. This is basically what we found. And yeah, I don't need the conclusion slide. I'm done.
Thank you. This was a really interesting, and I think that another valuable thing, it's not just the results, but also how, Angie, I'm sorry about mispronouncing your name, but how you and your team have like really harnessed this data in such an interesting way. I mean, this is like totally new, and you can definitely see the value of this kind of new age data. So what's your sense? This is sort of a broader question, like in the future when things kind of quiet down, do you think, you know, will we have too much hospital capacity? You know, is this, do you think this is going to lead to sort of a permanently lower level of healthcare utilization? Because this is critical for sort of predicting costs, predicting insurance company stocks, things like that.
I just got asked that question exactly by a news reporter who said that they're worried about premiums in the future. They want to set the premiums. So that, I think that's interesting. And I think that's an empirical question. There may be substitution to pharmaceutical interventions that last, you know, that dominate in the future over physician visits, for example, or increases in electronic prescribing that change how we see our physicians. I'm not sure. It's an empirical.
Great. Folks, there are a few questions that Kusli was answering. Does anybody want to follow up? Either raise your hand or just jump in.
So I see a question here. How do the data get from the providers to the database? The provider allows Health Jump access to their electronic records, and it's all automatic.
And the other thing that does play in here is this sort of change in actual frequency of disease, because if, you know, we found, well, you get rid of pneumonia patients, but certainly pneumonia and COPD have dropped a lot. But it's sort of interesting if you think that the actual incidence of disease has declined in say in certain kind, like maybe it's gotten worse for diabetes because people who are diabetic are at home and eating too much sugar. Versus, you know, some other kind of disease that may also kind of affect your results, but I'm not sure how that would go.
Yeah, I mean, there's a lot of, this is the thing, is that there's so much going on. So if we think about hypertension, for example, hypertension, you take hypertension drugs that reduce your blood pressure so you don't have a stroke. I mean, that's the clinical purpose. but there's also changes in stress level that are occurring. Less driving. There are maybe stress triggers that have been removed, not just added. So yeah, it's unclear whether there'll be changes in disease prevalence.
Super interesting. Okay, are we good to go? Thank you so much for terrific presentation. All right, Bill Evans, Chris Cronin, I've made you co-host, so you may take over the screen.
Great, thanks, John. All right, so I'm trying to share, let's see. Okay, can everyone see my slides? Yeah, and can you see my mouse as well? If I move it? Yeah, very good, okay. All right, so for those of you who I haven't met, my name is Chris Cronin. This is joint work with my colleague here at Notre Dame, Bill Evans. And my hope for this talk is to do two things. First, I want to provide some basic facts about COVID-19 in nursing homes, and then I'm going to detail the relationship between nursing home quality and both COVID, non-COVID mortality during the pandemic. And my hope is to leave you with three big takeaways. The first, I'm going to show you compared to lower quality nursing homes, higher quality nursing homes have had substantially lower COVID-19 mortality rates, and maybe this is something that we would expect. We're going to show that it's very likely that these high quality nursing homes are doing a better job of complying with CMS guidelines. They're doing things like keeping up with their PPE, they have fewer staff shortages, and they do a little bit more testing. Now, a little bit more surprising is I'm also going to show you that compared to lower quality nursing homes, higher quality nursing homes have higher non-COVID mortality rates. And we think that this is also consistent with these higher quality homes doing a better job of following CMS guidelines, namely they're exposing their residents to more extreme levels of isolation. Now, this second relationship, surprisingly, is driven by nursing homes that are in areas where the risk of COVID-19 is fairly low. And the relationship actually is so strong that compared to lower quality nursing homes, higher quality nursing homes in low risk counties have a higher overall mortality risk or mortality rates. And we think that leads to kind of a pretty clear policy recommendation, which is that some of these restrictions about visitors coming into the home and isolating patients need to be relaxed in more low risk places. Okay, before jumping into the data, provide a little bit of motivation about why we're looking at nursing homes. I think something we've understood essentially since the beginning of the outbreak is that the disease is particularly lethal for two groups, the elderly and then people with particular conditions like Alzheimer's, diabetes, and heart disease. And this is just very clearly borne out in the data. Here I'm showing you COVID-19 death rates per 100,000 individuals by age group. And you can see there's just a positive monotonic relationship between age and these death rates. Here I'm showing you Alzheimer's deaths by week for 2019 and 2020. And something that I think is coming into people's attention a little bit more is for particular diseases, death rates have just been a lot higher this year than they have been in previous years. And the timing's totally consistent with the onset of the disease. So for Alzheimer's, deaths have been 9% higher in 2020. If we look at diabetes, deaths have been 12% higher in 2020. And for heart disease, deaths have been 3% higher in 2020. And so all of this kind of motivates looking at nursing homes because these risk factors are highly prevalent in nursing homes. About 85% of nursing home residents are over 65, 50% have dementia, 30% have diabetes, 30% have heart disease. Okay, now given that we're going to look at nursing homes, we essentially have two options for data that we can analyze. The first option comes from state web pages. So 33 states are regularly updating their state dashboards with the number of cases and number of deaths that are occurring in nursing homes. And these are fairly large states. So about 83% of the total population is covered by these 33 states and 90% of nursing home COVID deaths. Now we want to look at we want to look at individual nursing homes because we're trying to say something about the relationship between quality and deaths. And so we're going to use CMS data. So this is data that's reported to CMS weekly by nursing homes. They started collecting this information the week ending May 24th. And the fines for not reporting are fairly substantial. So from the beginning, we've had a near census of nursing homes reporting to this source. Now the downside the downside of using these data is that there's a pretty clear undercount of nursing home COVID mortality. And there's a kind of a systematic reason for it. In the first week, CMS allowed nursing homes to report either the cumulative deaths up to that point or the deaths that had occurred just in that week. And you can see in the data that kind of overwhelmingly nursing homes reported the cumulative number of deaths, but there are some that just reported deaths from that week, which you can tell by comparing to the state dashboards. So everything I show you today, we're going to be looking at deaths as of September 13th, but you should know that everything that we're going to do, we've also done looking just at deaths since March 24th, where the data are a lot more accurate, and essentially all of our results hold up. Okay, so now for some facts. First, kind of to say bluntly, COVID-19 has been just a disaster in nursing homes. As of September 13th, 192,000 deaths in the United States, 74,000 in nursing homes. So about 38.5% of the deaths that we've seen from COVID-19 have been in nursing homes. Only about half of 1% of the population lives in a nursing home. We can also talk about death rates. So if you look at deaths per 100,000 individuals across the country, we have about 59 deaths per 100,000 individuals in the US. If we look outside of nursing homes, this is 36 per 100,000. Outside nursing homes, individuals who are over 65 years old, it's 208 deaths per 100,000. And then in nursing homes, it's just tremendously high. So about 5,600 deaths per 100,000. Over 5% of the nursing home population has been wiped out by COVID-19. If we compare individuals in nursing homes and outside of nursing homes, the death rate is about 150% higher in nursing homes. If we compare that to kind of normal times during 2018, it was 50. So the difference in death rates has gone up threefold. Okay, fact number 2, nursing home death rates kind of unsurprisingly mirror the local population. Here I'm going to show you a scatter plot that compares the state non-nursing home COVID-19 death rate to the state nursing home COVID-19 death rate. And you can see just a clear, positive, strong relationship between the two. So places that are at high risk, that's where folks are dying in nursing homes. Fact number 3, COVID-19 is not the only mortality risk. Here I'm showing deaths per week for individuals who are over 65 years old, starting in 2018 and 2019. If I compare that to 2020, we can see a spike in the total number of deaths that's totally consistent with when case rates went up in the US, so in mid-March, and that difference in deaths has persisted. So overall, I think we're north of 300,000 additional deaths this year. Now, what's interesting is if I take this black line, this total deaths, and I subtract away from it deaths that have been coded as COVID-19 deaths, you can see that we still have a substantial number of excess deaths in the US, kind of absent people dying from the disease. And so the thought is like, these are probably still associated with the pandemic. For younger people, you could think this is probably suicide, risky behaviors, or people drinking and then engaging in risky behaviors. For older individuals, one part of the story is people not getting healthcare that they should be getting. This is the over 65 population. We want to think a little bit more about nursing home, individuals living in nursing homes. So we could focus on a subset of individuals who are very likely to be in nursing homes, namely those who have Alzheimer's. So this is the CDC estimates of excess mortality for Alzheimer's patients through the end of September this year. They're estimating that about 30,000, there have been 30,000 additional Alzheimer's deaths this year, which you might think, okay, these people are in nursing homes, lots of people are dying from COVID in nursing homes. But if you actually look at what the number of people with Alzheimer's who've been diagnosed with COVID who are dying, it's a small fraction of that 30,000 additional deaths. So something's going on with this additional 23,000 people that are dying this year that wouldn't have died last year, but they don't have COVID. All right, the fourth fact, these deaths are highly correlated in just a few nursing homes. And so if we look at September 13th, just 5% of nursing homes account for 40% of COVID-19 deaths COVID-19 deaths in nursing homes. And actually 58% of nursing homes have yet to have a COVID death. And the second bullet point, you might think, well, this is just like geographic variation, right? There's some places that haven't been hit very hard with COVID yet. And so we considered then a sample just of nursing homes that are located in counties in the top 10th percentile for COVID-19 deaths. And we're also going to limit the sample to those with more than 100 beds. So we're getting rid of kind of small nursing homes that they don't have a death because they're just small, right? And then we're going to think about how many nursing homes in these high risk areas are avoiding death. If we look at May 24th, you can see that still over 30% of nursing homes in these really high risk areas have avoided having a single death. Right? If we fast forward to September 13th, we still have about 15% of nursing homes that haven't had a death. And you can see if we add these two bars, then we've got about 35% of nursing homes that their death rate is less than 2 per 100 beds. And so these two figures really kind of motivated the project for Bill and I, because we're looking at this thing, like there's some nursing homes that they figured it out. They're in like really dangerous areas and somehow they're preventing their residents from dying. Okay, so the research question we then have in mind, imagine you have a loved one that in the midst of the COVID-19 pandemic, you've got to find a nursing home for them to go to. Kind of what observables would you focus on? And the first thing that comes to mind is like, well, it still should just be high quality nursing homes. They've been thrown a curveball. It should be high quality nursing homes are the ones that are able to figure this puzzle out. Okay, so the research question then kind of becomes, well, are the highest quality nursing homes, are those the safest homes during the pandemic? Okay, so we're going to use a fairly straightforward statistical model to answer that question. We're going to use a negative binomial model for COVID-19 death counts as of September 13th. Our measure of quality, we're going to use the CMS 5-star ratings. For those of you who aren't familiar, there are 4 different CMS 5-star ratings for each nursing home, one based on state health inspections, one based on some staffing metrics that are reported by the nursing home, another based on quality metrics that are also reported by the nursing home, and then an overall rating that you can think is kind of a weighted sum of these 3. We're going to focus mostly on the inspection rating. It's thought to be the most objective because it comes from the state health inspections and isn't just from self-reported information by the nursing home. And even CMS, when they calculate this overall rating, they weight this inspection rating the highest. Okay, we're also in this model going to control for some confounders that we might think are both correlated with COVID-19 deaths and a nursing home's quality. So we're going to control for things like the nursing home's acuity index. This is a measure of how much care individuals in the home need, the profit status of the nursing home, the share of the residents that are over 65, the share that are on Medicaid, so on and so forth. We're also going to control for the local infection risk by controlling for the county level COVID-19 cases per 1,000 individuals. We'll do that with a 3-week lag because on average it takes, for someone who does die, they die about 3 weeks after they've contracted the virus. And then finally, we'll include state fixed effects. So on the next slide, what I'm going to show you, I'm going to report coefficients from this model as we move from 1 to 5-star rating. Okay, and so you can see pretty clearly that as the nursing home quality ranking increases, that the percentage of COVID-19 deaths declines. So this says that 5-star homes have 24% fewer COVID-19 deaths than a 1-star home. If we want to think about how large that is in terms of human lives, a 1-star home has about 3.3 COVID-19 deaths per 100 beds. That means that at a 5-star home, there's about 0.8 fewer lives lost per 100 beds. Okay, so the next question we were then interested in, if we see these high quality homes reducing deaths, we want to know how they're doing it. I can start off by telling you what they're kind of surprisingly, what they're not able to do. Quality is not predictive of any resident cases or having any staff cases. So these high quality homes don't seem to keep COVID out of the nursing home entirely. We can also show that high quality homes aren't preventing staff spread. So conditional on a staff having a case, we don't see that high quality homes have fewer overall cases among their staff. What high quality homes seem to be doing is they prevent resident spread. So conditional on having a single resident case, high quality homes have fewer total cases and the magnitude similar to the death prevention. So 5-star homes have about 23% fewer cases than 1-star homes. That still begs the question, kind of like, how are they doing this? And we're limited in the data in terms of what we can actually see. What we can see in the data are things like how many staff shortages has the facility had during the pandemic, and have they had any PPE outages across a bunch of different PPP metrics. And we can say kind of very confidently these relationships are really strong, that high quality facilities definitely have fewer staff shortages and fewer PPE outages. Okay, now again, this also is kind of like consistent with this idea that high quality facilities are following CMS guidelines. A key part of the CMS guidelines pertain to protecting residents by preventing visits into the home, and also by isolating residents. You can think both, they can do that strenuously or not so strenuously, conditional on someone nearby becoming infected, or just allowing residents to interact with one another during mealtime and during kind of common activities. And so that was the next thing we really wanted to think about, is kind of what are the implications of those visitation policies. To provide a little bit of background, the very first memo that was released by CMS to nursing homes in light of the pandemic was on March 13th, and literally like top of the line, bold letters, red, italics, everything they could do to get your attention. They said that facilities should restrict visitation of all visitors and non-essential healthcare personnel for certain, with the exception of certain compassionate care situations such as end of life. Among the additional recommendations, CMS recommended that nursing homes canceled all communal dining and all communal group activities. So essentially CMS was saying, for the time being, while we're trying to figure this out, have everyone stay in their room and limit their contact with anyone else. These guidelines were revised about 2 months later on May 18th, but the criteria for allowing outside visitors into the home, as most of you are aware, were incredibly strict. So in order to have visitors come into the home, they were recommending you needed to have community spread declining for 14 consecutive days, no new cases in the home for 28 days, no staff shortages, and the ability to test everyone every week. So pretty strict. And what that meant is that most nursing homes ended up with very little visitation, if any, through the end of the summer. As a result of that, towards the end of the summer, we started to see all this anecdotal evidence that this isolation was really taking its toll in nursing homes. So lots of op-eds in popular newspapers arguing that that there was an incredible amount of despair and depression and within the homes among the residents, and this was even potentially costing human lives. So we wanted to see if we could kind of speak to like whether or not that was actually taking place. All right, so we're going to return to the original statistical model, the negative binomial model, and all I'm going to change is the outcome variable. Instead of looking at COVID-19 deaths, I'm going to look at non-COVID deaths in the nursing home. And the question, again, as a reminder that we're trying to get at here, we're asking if high-quality nursing homes prevented COVID-19 deaths by adhering to CMS guidelines, do they also experience more non-COVID deaths by exposing residents to extreme isolation? And what I'm going to show you, same as before, I'm going to report coefficients as we move from a 1 to 5-star inspection rating. And sure enough, what we find is that as nursing home quality increases, we have kind of large and statistically significant increases in the non-COVID death rate. Again, if we want to think about how many human lives this is, 1-star homes have about 7.9 non-COVID-19 deaths per 100 beds. So in these high quality homes, we're seeing about 0.7 additional lives lost per 100 beds. The natural thing to do then, if we have COVID deaths and non-COVID deaths, we can look at total deaths and how that relates to quality. You can see from this figure that, so again, we're just negative binomial model where the outcome variable is total deaths. And we see no statistical relationship between nursing home quality and the total number of deaths. Okay, so like those findings, I don't know, we come up with this and we think this is hopeless. This seems like kind of a damned if you do, damned if you don't situation. We've got high quality nursing homes that seem to be able to prevent COVID-19 deaths, but a terrible result from that is through exposing their residents to isolation, we have these non-COVID deaths where the effects essentially wash each other out. So the question is like, is there anything we could do about that? So the next thing we thought is, well, what if we focus on low risk places? What if visitation and nursing home activity restrictions, what if they were lifted just in areas that we don't see much COVID-19? So to try to speak to that, we return to this non-COVID death model, but we're going to split the sample by county case rate, whether or not the nursing home is above or below the median county case rate. So the first thing I'm showing you here, outcome variable is non-COVID deaths. and I'm focusing on the high risk areas. So the county case rate is above the median. And what you can see pretty clearly is there's not much of a statistical relationship between nursing home quality and non-COVID deaths in these high risk areas, which means the relationship that I showed you previously has to be driven entirely by low risk areas. So here I'm showing that if the nursing home's in a county with a case rate below the median for the country, 19% higher non-COVID death rates in the high quality nursing homes. Naturally, then we look at all deaths or total deaths. And again, in high risk places, we're seeing not a strong statistical relationship between nursing home quality and the total number of deaths, the total number of deaths. But in low risk areas, we see that higher quality nursing homes have more overall deaths. For a one-star nursing home, let's see, my video is blocking. Okay, for a one-star nursing home, we have about 12 deaths per 100 beds. So you can think these high quality nursing homes in low risk areas, they have about 1.8 additional lives lost per 100 beds. Let's see. Okay, so real quickly, maybe some of these have come up in the chat. I can't see the chat. Some alternative explanations that you might think about. You might think maybe high quality homes always have more deaths. This seems pretty unlikely. We haven't been able to get death data from previous years. But in our data, we can see that high quality homes have much lower Medicaid rates of residents who are paying with Medicaid. They're much younger residents at high quality homes, and the homes are less likely to be for profit. So kind of all three of these things are predictive of higher death rates. So it seems unlikely that this is just always true of high quality homes. Something that we dedicate a lot of time to in the paper is this idea that maybe homes are strategically reporting COVID-19 deaths. You could imagine high quality nursing homes that are well managed might want to recode deaths away from COVID-19 in some way to help their reputation. With regard to that, I'll remind you, this non-COVID excess death relationship is driven by low risk areas where very few people are actually getting COVID. In the paper, we even show if we limit the analysis to counties where there's not been a single COVID death period, that still high quality homes are having more non-COVID deaths than low quality homes. Finally, conversation I had last week suggests that, maybe this isn't, and actually the previous talk, maybe this isn't isolation, maybe this is access to healthcare. Maybe that's true. I still think that's part of an isolation story, that people are isolated and they aren't going to get healthcare. At the same time, again, excess deaths here are in low risk places where hospitals aren't at capacity. So, if hospitals aren't at capacity and a patient really needs to go to the hospital, you would think that a nurse would recommend that they go. Also, remember, many of these excess deaths seem to be among folks with Alzheimer's, where it's not really clear that lack of access to healthcare would be the main driver. Okay, so to conclude, high quality nursing homes, we show manage to protect their residents from COVID-19 mortality, but this seems to come at a cost, namely increased isolation, excess non-COVID mortality. That latter relationship is heavily concentrated in homes with low COVID risk. So we think what this means is that just more nuanced policy is needed. Namely, we should allow kind of relaxed visitation and communal activity guidelines in areas with little to no risk. And actually kind of near the time that we finished up this paper, CMS updated their guidelines kind of exactly in this direction. Okay, so that's everything I have. Thanks.
A lot of information, lots of questions. And Bill has been very effective in responding to them. So Bill, as I say, if you feel like jumping in, feel free. I think there seem to be a fair number of questions about, well, what is it about, what makes these 5-star nursing homes different? Is it that they're more willing to kind of look after the patients in the nursing home? Is it that they have higher paid staff that aren't kind of going back and forth to other nursing homes? And some of the questions seem to be, addressed when you look at places that have like 0 cases in the county, although again, that's, sometimes counties are pretty small. But I'm wondering, do you have any thoughts about did it seem as if in states with in nursing homes with fewer kind of restrictions on visitors, do you have any way to sort of test that hypothesis directly, that it's visitors versus maybe nursing home residents who see one another and chat with one another, or what's the mechanism?
Yeah, so that's a good question. We haven't dug into state policy much. So what I can say is quite literally every state in the United States, followed this CMS guideline on March 13th. By early July, about half of the states in the US were starting to allow visitors back in, but with pretty tight regulations. So people had to wear masks. They were really strongly pushing that visits take place outside. And even now, most states are now allowing visitors, but there's an interesting like north-south divide that like southern states, it's like you have to be outside, and northern states are having to make different accommodations because it's just too cold to be outside. What we've actually dug into in the paper is just what I presented. So we can see that these high quality nursing homes have fewer PPE outages. That suggests that they're managed better and they're kind of better able to forecast what they're going to need. They also have better supply channels that allow them to get the PPE. But in terms of like distinguishing between inter-nursing home activities and visitors, we would just have to do more work looking at state level policies and we haven't done that yet.
So yeah, so there are also these questions about that when Judy Chevalier talked about the multiple staff going back and forth. But again, that would be ideal if you had cell phone data too, but that might be a little too much.
Sure.
Anyone else want to jump in? And we have a few minutes.
I have a question. This is really interesting, just a lot of information too. So apologies if you said this and I missed it.
That's okay.
But it's the mystery of the higher deaths of non-COVID deaths in these 5-star places or 4-star places. If you went back a year in time and you looked at mortality rates in nursing homes, again, just divided the way you've divided these counties below and above the median, what would you see?
Yeah, I'm not really sure. And actually, this is a room of people who knows a lot about available data sets. And if someone had a recommendation for how we could go and find death data at the nursing home level in previous years, that would be fantastic. But to my knowledge, we don't have that. So yeah, without data, I'm not really sure. I honestly, I would expect either no relationship between quality and death, or I would actually probably expect the opposite.
Yeah.
As I said, the low quality nursing homes, when you look at the characteristics of their residents, way more likely to be on Medicaid, they're older, they're more likely to be a minority. So lots of things that we would think predict death, you see that at the low quality nursing homes. And so that, in previous years, that's what I would expect, but I can't verify.
So they're older, meaning the fraction above the age of 65 is higher, is that right?
That's right.
Yeah.
But it's kind of a black box, right? Because if they're, given the death is linear more or less in age, like the age structure within those nursing homes, it might be worth encouraging somebody to do qualitative work on this.
Yeah.
And yeah.
I don't disagree. I mean, the pattern is somewhat predictable, right? So like as people age, they maybe enter their first nursing home not being on Medicaid. They run out of money, then they qualify for Medicaid. That's naturally when they're older and they're sicker, and they transition to a worse nursing home as a result of that. So literally, like my grandmother-in-law just went through this process. So it's sensible that kind of these low quality nursing homes are made up of older, sicker people.
Great. Andy Levin, did you have a question?
Oh, yeah, this is a really, really interesting paper. Just wanted to mention that the catastrophe in the nursing homes was really during the first several months of the pandemic. I was just checking the CMS. I mean, CMS is incredibly transparent about this, so you can download the individual case data for the nursing homes. But since June 1st, according to this spreadsheet, I may be looking at a different source than the authors, but 44,000 deaths since June. the total COVID deaths in the United States since June is like 150,000. So the fraction of nursing home deaths as a total of, in the first 2 months was huge. But the good news was that, and you know, the evolution of understanding of how to protect people in nursing homes improved a lot. So the good news, I think, one of the messages on one of their first slides was that this was a catastrophe, not just in the United States, but in many countries where the nursing home deaths were horrible during the first 2 or 3 months. And then the practices really did start to improve a lot. Still not perfect, but a lot better.
Yeah, so I totally agree. I do think it's interesting, and I alluded to it, but I wasn't able to show it today. So a couple things. One, most of our mismeasurement is in those early northeastern states, like New York, like New Jersey. When we drop them from the analysis, this relationship between nursing home quality and both COVID deaths and non-COVID deaths looks exactly the same. It's also the case that if we only measure new deaths since late May, again, the relationship's totally the same. And so this, you know, if you believe this story about us having these excess deaths because we're exposing people to isolation, and that's what this nursing home quality gradient is picking up, that relationship hasn't gone away. That still exists. But I will agree, yeah, the magnitude of the problem is probably lesser than it was.
This is great. One final question, let me just paraphrase Jim Perturba's sort of question, also kind of aggregating up Edward Norton's question. How much do you think of this is sort of coding discretion? 5-star nursing homes are clearly good at coding, getting 5 stars. So is there any correlation?
Yeah, so we were really worried about that in the paper, spent a lot of time on it. I think the most convincing thing we can say is again, if we go to counties that literally haven't had a COVID death, and we look at the relationship between nursing home quality and non-COVID deaths in those counties, it's still the case that high quality nursing homes are having more non-COVID deaths. So in those areas, like there's essentially there's very little risk, and it can't be miscoding in those places.
Got it. Great. Okay.
Thank you for your time.
This is a really good presentation. Here. Maria, I've made you co-host. I don't know who, if you are presenting.
Yes,
or...
I'm presenting.
Okay.
So thank you, John. Let me share slides and hope that works. Can folks see that?
Yep. Looks good. Okay, yep. Full, and just a full screen.
Great. Well, thank you so much for including us in the program. This is a joint work with Victoria Udalova at US Census, who I think is on the call, as well as 2 other of her colleagues at US Census, Katie Gnadik and Keith Finlay, as well as with Jeff Cox, who I think is also on the call, who's a graduate student at MIT, and Amy Finkelstein. And so this I would describe relative to the previous papers as sort of the macroeconomic version of this discussion. In particular, we're going to look at the impact of COVID-19 pandemic on all-cause mortality by various demographics, national and state by state. And we'll give you a lot of data and facts, but kind of fewer explanations, and are hoping to actually, you know, generate a discussion, people trying to help us understand these facts in future work. So would be very grateful for any of your comments on that dimension. All right, so what was the motivation for us of doing this project? The original motivation, and you know, it took us a while to actually get the data and do this, was that there was lots of evidence at the start of the pandemic coming out on COVID attributable mortality, and we're all counting COVID deaths. However, it was less clear how access all-cause mortality was developing, and especially so by demographic groups and across different parts of the country. The other kind of 2 parallel discussions that were happening and seem to not be truly connected is that we were observing, people were either talking about mortality impacts of the pandemic or economic impacts, but not both at the same time. And as a result, we feel like we know less about how and especially why the early economic and health impacts of the pandemic varied by demographic groups and geographically. So we will be interested eventually in trying to understand why. In this particular talk, I will talk more about how, so we're going to document some facts, and then hope again to open the discussion of trying to understand why there was this geographic and demographic variation in both the economic and health impacts of the pandemic. So why is it important to think about excess all-cause mortality, as well as why there are differences across different demographic groups and geography? Well, in some sense, these are crucial inputs for policymaking for two reasons. One is understanding who is actually the most affected in a whole package, right? So if we don't talk about purely COVID deaths, but all deaths, as well as understanding the differential impacts of potentially direct effects of infections versus indirect effects of the pandemic. And I think we've talked a lot about various indirect effects today, as well as in the previous session, there was a lot of discussion of deaths of despair and so forth that could be resulting from indirect effects of the pandemic, and understand and kind of whether it's one or the other can lead to very different policy implications. So understanding that is important. Again, we will be kind of delivering more facts towards that, but not necessarily really answering the question at the end of the day, but hope to open the discussion. So what are we actually going to do in this project? We're going to use administrative data for the first full month of the pandemic, so April 2020, to compute excess all-cause mortality by different demographics groups and geography. We're also going to supplement this with survey data from CPS to measure the economic impact by different demographic and geographic groups. And then our plan for next steps is to try to link various survey and mortality data at the US Census to try to understand what are the actual causes and consequences of different demographic and geographic variation in both the economic and health impact of the pandemic. We're also hoping to expand the timeline. But today I will basically be showing you all the results will be for April 2020. So think about this as the very first month of the pandemic. So we're going to use sort of three basic sources of data. So we're going to, some of our analysis it will rely on CDC vital statistics data that has been kind of the most used in the analysis of this pandemic. We'll be using the CDC data to both compare our estimates that will be coming from other administrative data sources on the national impact on mortality, as well as to try to understand what fraction of deaths that we're estimating in all-cause mortality are attributable to COVID deaths. So what is kind of what are the non-COVID deaths in the data, as well as using CPS survey data to measure some of the economic outcomes. Our main source of data will be individual level administrative data and census data. So we will be using census version of the Social Security Administration's NUMIDANT file from January 2011 to April 2020. So for those of you not familiar with the NUMIDANT file, basically imagine that's a list of everyone who in the US ever has a Social Security number. People are born, they kind of get into the NUMIDANT file, so we observe their date of birth, and then whenever they die, we observe their date of death. So it's kind of a rolling file of all individuals who have a US Social Security number. That's kind of a rough definition of that. So from the NUMIDANT file, we'll be able to observe people's date of birth as well as sex. Then we're going to use census internal linkage apparatus to link these NUMIDANT data to 2010 census, decennial census. Why do we want to do that? Is to get a measure of self-reported race. So the interesting kind of measurement aspect here, if you start looking at racial disparities in mortality, is, how do you measure race? So there is some measure of race in SSA NUMIDANT directly that comes from services and applications. And then we think kind of, there is a lot of work that has been done by the census, thinking that, self-reported race in the census is actually kind of the most accurate measure that we have. So that is where we're going to link census to Numident to get a measure of race. And then in addition, we'll also link Numident to the address database at the US Census to get geographic information. So a couple of notes for those of you just interested in the data, a couple of notes on kind of data quality. So there are actually interesting differences on the reporting of deaths between the CDC vital statistics and Numident. Some of this, like if you look at how death data is generated, it comes from very different channels to the vital statistics versus to the Social Security Administration reporting. So you will see that you know, some of the numbers that you might see in our data might not quite match to the numbers that are reported by the CDC. Roughly, they're sort of in the same direction and very similar, but there are some discrepancies. And there are certainly differences in reporting of race, because in the vital statistics, race information comes from death certificates, while we're going to be using race reported by individuals to the census. So the advantages of using Numident linked to census relative to the CDC data is that first, we're going to have, as a result of kind of Numident being a roll call of everyone and observing date of birth of individuals, we're going to have the same data for numerator and denominator for mortality. That is important because when you're using CDC vital statistics data on deaths, CDC doesn't actually report kind of the population level. What is the population for which you want to take these deaths as the numerator if you want to compute mortality. So instead you have to kind of go to census data and try to just compute the general number of individuals in the US. So you sort of have a measurement error in the numerator relative to the denominator, which we avoid by using Numident. And second advantage is that we're going to use race from the census, which is self-reported rather than from death certificates. So that's as much for our data. Let me give you just some very brief summary statistics on this Numident data set linked to 2010 census, just so that you have a sense of kind of what are the characteristics of the population that we're going to be looking at. So if you focus on the first column here, these are April 2020 numbers, pure 2020 numbers, where in the data we'll have 241.5 million individuals. This is after our various sample restrictions for people for whom we can observe race, can link to census and so forth. Out of these, we have 276,000 deaths. I think the primary, average age in the population is 45. There are about 50% women. So one kind of thing that will be important to keep in mind when we're doing our analysis by race is how many what are the fraction of different races in the population, which essentially will guide our statistical precision, right? So how many people of different racial categories we have. So about 66% of the population will be white individuals, 15% Hispanic, 13% will be individuals who have reported being Black non-Hispanic, and then 5% Asian non-Hispanic, and then less than 1% of other race groups. And this is pretty similar for April 2020 and for the whole 10 years between 2011 and 2020. So there's been not much differences over that decade there. So what do we estimate? Here I'm actually showing you the aggregate data from the CDC, but we matched it also to Numident, so this is pretty similar. So we observed substantial aggregate excess all-cause mortality in April 2020. So panel A here is estimating, this is actually very similar, methodologically very similar to what David Cutler was showing at the beginning. So that spares me a bit of an explanation of what we're doing here, but it's pretty simple. So we're basically plotting a trend. So the red line is the raw data of mortality per 10,000 people for the total population in all months of April in various years. So 2011, April, 2012, April, and so forth. So the red line is just raw data, and you can see that it fits a linear trend very well. So then we just project this linear trend out of sample to 2020, so that the predicted all-cause mortality in April 2020 would have been roughly 7 individuals per 10,000, but the observed all-cause mortality in April 2020 was 2.4 per 10,000 individuals more. So it's about 9.4 individuals in total per 10,000 who are dying. And we calculate that at the end of the day, the excess all-cause mortality was 2.5 individuals per 10,000 people. And out of that, 75% are COVID attributable deaths. So there is a pretty substantial number of these that are of these deaths that are either not coded as COVID deaths. So there was just the discussion that Jim Paterba started on, how are COVID deaths coded. So from that perspective, it's actually really important to look at all-cause mortality, especially if you worry about differences in coding across states and across different time periods. The other panel here is showing you a similar exercise where we're taking CPS data and are trying to show you the effect of the economic effect of the pandemic. So there are obviously many different ways to measure that. What we did here is just taking, computing the share of people who were employed relative to the population of these individuals in different Aprils of different years. And what you can see here that employment was generally, employment to population ratio was generally rising before 2020. And the predicted trend for April 2020 was about 61% of individuals employed, but what we actually observe is almost 10 percentage points lower employment. So you can see that there was a pretty substantial increase in mortality and a drop in employment, as we kind of all know from various other reports. So these aggregates, however, mask quite substantial variation in geographic impact. And what we observe here by just using this really aggregate data is that there was large differences in how geographic incidence looks for mortality versus economic impact. So for mortality in aggregate in the first month of the pandemic, which is not surprising, we see this very concentrated impact of the virus in New York and New Jersey, while the economic impact is quite geographically widespread, even already in this first month of the pandemic, which is presumably attributable to the implementation of various policy responses, as well as just to how economy, is connected across different states. So why am I showing you this map and I talk about racial disparities? Well, I want you to kind of have this as a snapshot for when I'm going to show you the geographic variation in racial disparities in all-cause mortality, because this may be kind of informative in interpreting these results, and especially thinking about the potential indirect effects that may be contributing to the geographic variation in mortality gaps by race. Okay, so now let's go to these estimates by race. So these aggregates that I've just shown you for the whole country, in fact, mask large differences in excess mortality by demographic groups. And here we're going to focus on differences by racial groups. So we estimate this for 7 different race categories in the paper. Here I'm going to show you only a couple of estimates. So this is the same exercise of predicting mortality trend and comparing it to the observed numbers by different races using this Numidant data. So this is mortality per 10,000 individuals for white non-Hispanic individuals, and this is panel A, and then in the right-hand side panel, you see this for Black individuals. What you see are kind of 2 facts. One is, in general, mortality is much lower among Black individuals in the baseline, and that is primarily driven by age composition, as I'll show you in a moment. But what is striking here is there are large differences in the increase in mortality in April 2020. So for white individuals, we observe 2 per 10,000 excess mortality versus predicted about 10 per 10,000. So an increase of 2 over 10 per 10,000 deaths. While for Black individuals, we observe an increase of 6 per 10,000 over the baseline of predicted 8 per 10,000. So it's almost doubling of mortality for Black individuals and an increase of about 20% for white individuals. Both of these are very large increases, but it is striking that the differences are quite pronounced across races, and we observe, different versions of this for other different races. So one thing that is important to keep in mind here is that there are large underlying differences in age distribution by race groups. So when we see various raw data points reported in various newspapers or whatnot, it is important to note the underlying age distribution. Actually, here is a table that just shows the average age by each race category that we observe in the data. So on average, people in the US are 45 years old, but you can see that Hispanic individuals are substantially younger, so 38, 39 years old on average. White individuals are 47 years old, and Black 42, and then Asian 45, American Indian and Alaskan Natives, non-Hispanic 42, and Hawaiian and Pacific Islanders are again much younger at nearly 40. So keeping in mind that the age distributions here are quite different is important when trying to actually make meaningful comparisons across races. So in the next table here, and this is sort of a lot of numbers, but I wanted to show you sort of the full scope of what we do for each race category. What we do is that we compute excess mortality that I was just showing you in the graph. So these numbers here correspond exactly to what we saw in the graph for white and Black individuals. We see this 2 per 10,000 individuals excess mortality, and for Blacks, 6 per 10,000 excess mortality. So this is unadjusted. And then you can see when we equalize age distributions, these numbers change quite substantially. In particular, so we are normalizing here to the age distribution in the full population. As a result, the excess mortality for white individuals goes down because they tend to be on average a little bit older. And for Hispanic individuals, for example, goes up substantially because they tend to be substantially younger. So these are the largest differences. We actually don't see too much impact of adjusting for sex composition or for geographic variation. Geographic variation is important for smaller racial groups because of the differences in where people are located in the country, obviously. But then ultimately our adjusted estimates where we're adjusting for age, sex, and state suggest that there was 1.5 excess mortality per 10,000 among whites, 4 among Hispanic individuals, 7 among Black non-Hispanic individuals, and so forth. So again, here we see that there's large racial disparities in aggregate at the national level. So the other interesting point, so these are kind of just precise estimates of these national differences. The question is, how do we try to understand these? And one way to try to understand this is to first look at the geographic variation in how the levels of excess mortality vary across the country in the same first month of the pandemic by race. So what I'm showing you here are 2 maps for white excess all-cause mortality in April, as well as for Hispanic individuals. And you can see that there are some similarities in the patterns in the sense that New York and New Jersey is always going to be more pronounced for everyone in April. But then there are also kind of a lot of states where here we see quite pronounced excess mortality among Hispanics, but not so much necessarily among whites. And actually, when we put this into a relationship, it's easier to see the differences in the gaps across states. So what we're doing here, so now this is comparing white and Black individuals. So here we have white non-Hispanic excess all-cause mortality on the x-axis and excess all-cause mortality for Black individuals on the y-axis. So there are kind of 2 things you will note. One is that the scale of the axis here for Black individuals is kind of much more pronounced. So there is much higher numbers in some states. In particular, in New York, excess all-cause mortality for Black individuals was more than 30 individuals per 10,000. So these are really large increases. And the other thing that is notable here is that there were several states where we observed nearly 0 white excess all-cause mortality, but already in April 2020, high Black and Hispanic all-cause mortality. So this is interesting because if you think that, you know, in some sense, if white all-cause mortality is measuring the direct spread of the virus in some sense, then we're observing this excess mortality among non-white individuals in states where potentially the direct impact of the direct viral impact of the pandemic may have been relatively limited, suggesting that it is conceivable that these are driven by sort of indirect effects of the pandemic, or there is something very special about how the pandemic in those states was only spreading among non-white populations, for example, which seems a bit less plausible. So that's kind of it for
wrapping
our,
up, maybe. Sorry.
Yeah, sorry, John.
I want to make sure there's time for questions and things.
Yes. So I'm going to kind of conclude with the slide. So I think our main takeaways here is that we observe pronounced geographic variation in the pandemic's impact on health and economic well-being at the national level. That is not surprising. We observe large differences in the impact by demographics, by age and race in particular. I haven't shown you the results for age given time, but by race, you can there are large differences. And then we also observe geographic variation in these differences. So across states, the gaps in excess mortality by different races vary a lot. So what can explain this geographic variation, and hopefully people will have more thoughts in the discussion, is one is obviously the direct impacts of the virus. Viral exposure, transmission, or fatality rates may vary across states. To explain the gaps, we will need to have more than that. We'll have to have some kind of differences that are varying by race across states rather than just as geographic variation. And then similarly, indirect impacts of the pandemic, such as economic impacts, motor vehicle fatalities that were talked about previously, healthcare utilization, and so forth. So our next step is trying to understand the mechanisms that we think are crucial for policymaking of what is driving this geographic variation. Is it the direct or the indirect effects of the pandemic? And I think this is generally important for understanding not just the COVID-related policy, but also the general causes and consequences of differences in health by socioeconomic status. We hope to do more work by merging in more various data sources, but also just curious to hear what people think are potentially the mechanisms and policy implications. Thank you. Hopefully I didn't completely run out of time.
Now we still have some time for a few questions and thoughts. I can't wait to see May and June. I just think patterns are just going to be like totally different. Amy has volunteered since she's been sort of monitoring. So Amy, do you want to take the discuss kind of the questions?
Yeah, I actually, you only told me towards the end that I was volunteering to discuss the questions. So I was actually paying attention to them, but not necessarily collating them. So many of them I tried to respond to, and hopefully we can get the chat from the conference departments, so we'll see them all. There are a bunch of questions. Angus raised it, and I think Bill Evans did as well, about doing things by finer geography, like New York City versus the rest of the state, or urban versus non. That's definitely on the to-do list. There was a terrific question about sort of how much of these racial differences are explained by differences in pre-existing conditions, which we would love to do. And I somewhat unfairly asked the person who made that suggestion if they could come up with any data, and he politely responded that he's not the health economist on the call. So I put it to the group. Someone put in the chat that, of course, we at the county level, we can take data from the BARFIS, but we don't know of any way to do that yet at the individual level. And then finally, Bill Evans had a fantastic suggestion about, narrowing in on the counties where there are no COVID deaths, say by May 1st, and trying to look at, impacts there. So, and there were many other comments, and I'm sorry that I'm not getting to them all now. I would say the main thing, we're very much eager, really, everyone always says they're eager to hear feedback, but we really are, in the sense of, as Maria said, we now have this apparatus set up. We can look over longer time periods. We can look at finer geographies. We can link to some additional demographics like education and occupation in the ACS. And honestly, we'd love to hear from you what you think are the hypotheses for what we're currently finding that we could explore, or what you think are the interesting questions we should be looking at in these data going forward.
So actually, and people should feel free to raise their hands or just jump in, but there were a few questions about like, well, what's the difference between this versus the CDC data? And there was a, Victoria, I know you sort of discussed it a little bit, but maybe could you talk a little bit about that? Because why
sorry,
we should use
there were
it.
two, I think. So is the question, how do our results compare? Because that was one set of questions, and the answer was, Jeff put it in the chat, we're comparable. They're where we can do the comparison, they're very comparable. Or are you asking more about why we would use these data rather than the CDC data?
The latter, yeah.
Okay, so I will defer to Victoria, who's the expert, but just at a very big picture level, there's the denominator point that Maria brought up, which, you know, that we don't want to, especially when you get to smaller and smaller demographic groups, trying to estimate population is challenging. But also, at least currently, the CDC publishes mortality, you know, by say race, but not race by age, by state, by whatever. But Maria can talk much more knowledgeably about some of the differences between the two data sources. Sorry,
yeah, I mean,
Victoria,
there are some differences in terms of, you know, what is included in which data set, and we can debate ad infinitum kind of what, you know, what is better. It depends on what you want to measure. But I think at the very, like at the statistical level, it's just for Numidant data, we have individual level data, so we can do any type of, you know, comparisons and adjustments, while CDC data, as far as we know, at least for now, is reporting a lot of things at aggregate level, and then a lot of things are masked, especially once you start looking at races by state, by age. Even if it is theoretically reported, in practice they will mask a lot of the data, so it's not really usable if you want to do, you know, and certainly if you want to link it to any individual level comparisons, then you can't do that with CDC data.
Yeah, and this is Victoria, and I would just add to that there's actually been a lot of work looking at sources of race and ethnicity data, and data on race and ethnicity that CDC gets frequently is reported by funeral directors, and so kind of there is some measurement issue around that, and so we're able to look at self-reported data on race and ethnicity, which we think is a better measure of that.
This is great. Good. Well, thank you. It looks like there's the chat goes on, but I think it's time to take a break for.
Sorry, John, is there a way that we can get the chat so that?
Oh yeah, totally. Yeah, no, the chat comes to me. In fact, a little known fact that I learned from running webinars before is that oftentimes, like even Amy, if you're emailing like Victoria saying, what's wrong with that Skinner guy?
Oh no, you're gonna see all that?
I think it all comes down to me because this is but anyway, I promise not to look. This is always useful to know, but yeah, private chat is not private.
Oh man.
Amy, if you look where you type in your chat, there are the three dots. If you click those three dots, there's an option for save chat.
Oh, okay. Do I get to see the private chats?
You might, but anyway.
Thanks, David.
So we're giving you 15 minutes for lunch, maybe a few minutes less, and then as Amy suggested, we resume at 12:50. Thank you, Amy. And very much looking forward to hearing from David Weir and about what the HRS is doing to track people through the pandemic. So thank you all. Terrific group of papers. Thank you all, and I'll see you at 12:50.
Thanks.
Hi, John. This is Rob. Can you make me the host quickly? I'm going to see if I can work something out. Thank you.
I will.
Hi, I'm going to make you the host again, John. Sorry, my idea did not pan out.
Thank you.
All right, everybody, welcome back. I hope people have lunch or at least got a chance to just stretch for a couple of minutes. So we're going to pick up with what I think are some fantastic sounding papers in the afternoon. So the first is going to be by, I saw David Weir and I saw Helen Levy, and I also saw Ken Langa, and including Jessica and Gabor, on the effect of COVID-19 on older Americans, preliminary results. And I think Rob has given you the control.
So Gabor has control. He'll do the slides. I'm going to spend just a few minutes at the beginning, and then Gabor will talk about the results.
Okay, however you want to do it, take it away.
Thank you, David and John, for including us. It's been great to see such innovative use of novel data sources. We're going to change that now and look at something much more traditional, and that's the health and retirement study. Gabor, have you got slides? Well,
yeah, it's coming.
Okay.
There they are. I hope. Do you see them?
Not yet.
Not yet. You are shared. You are. Okay, how about now? Do you see it now?
Nope.
Oh, that's odd. It says screen is shared. No, oh my. Let me try to share it again.
The first time it was almost there. It just didn't quite connect.
Yeah, something might have happened. Okay, so let me do this again. Sorry about that. Mm-hmm. Oh my goodness. Yeah.
Well, I can start.
I know that
All right.
There we go. Perfect.
All right, thank you. So this represents work collectively by the management team for the HRS, who David named previously. Next slide, Gabor.
Trying. Yep.
Okay. So just a quick outline of what we'll do. Next slide. All right. So the HRS began its 15th biennial wave of data collection in March, beginning of March. And of course, by mid-March, all in-person research contacts had been stopped everywhere in the country. HRS was fortunate in that we've been for some years now a mix of telephone and in-person interviewing with a questionnaire that works pretty much equally well for the common content in both modes. So we were able to continue in telephone. And essentially, our number one priority has been to keep the panel going through this to maintain the consistency of the study and its rhythm as the most valuable thing we could do long term. But at the same time, we recognized that this pandemic was having a big influence on people's lives, that to not ask them about it would seem odd to our respondents, and to not collect some data about it would be a dereliction of duty, I guess. The problem is that unlike some studies which stopped doing their data collections and went to do a COVID-focused thing, we were doing a 90-minute to 2-hour interview, and we couldn't really tack on a whole nother data collection to that. So we embedded within our core data collection what we're calling the COVID-19 project. And that consists of about a 10-minute added set of questions that are in the core interview, which is now always by telephone, an open-ended question about individual experiences that we'll be transcribing, and some additional content in the psychosocial leave behind questionnaire, where we have a little more flexibility about adding things. We also have some additional future plans that we're not going to talk about today. We've actually begun now mailing saliva kits to respondents to do antibody testing, and we will be doing a mail questionnaire to all our respondents in 2021 to capture more of what's happening now and will happen in the beginning of next year. Vaccines in particular. Okay. The other thing you have to know is the sample in HRS has since 2006 been split into a group that gets an in-person interview we call the enhanced face-to-face or EFTF interview, and the half that gets it primarily by telephone. And then people alternate ways in terms of which mode they're in. So we had half of the sample scheduled for in-person interviewing, and they had not been released when the pandemic hit. And so we decided that they represented our best opportunity for a truly random sample of COVID-related content. So we held them out from the field until June while we developed the new content, tested it, got it into the field. We are going to be talking about early release of data from the group that went out in June. Next slide. Why is it important that we do this in HRS? Well, we're a nationally representative sample of what people have just been showing today, reminding us are the most vulnerable groups. People 55 and older, over samples of Blacks and Hispanics. We have this long prior history of relevant health, economic, and social measures, and we hope long follow-up. We have prior genetic and blood samples in repository for analysis of biological determinants, and we have linkages to Social Security, Medicare, and Medicaid. Next. We also span the geographic variation in known cases. So took the Hopkins data and put it into quintiles and asked what fraction of the HRS sample is in each quintile. And it's not exactly 20%. We overrepresent the most hardest hit areas slightly relative to the others, but it's a pretty good balance overall. Next. So timing, as I said, we set out phase 1 in June. And now, for the first time in our history, we've actually released data from a wave that's still in the field. So we got to around a 60% response rate in that first group and decided to go ahead and make an early release of those data. And they are out there and publicly available for you all to use. It's the whole HRS interview plus this new COVID content. And so that's all I have to say. Now, Gabor will show you some results from that.
Thank you very much. Do you hear me? Okay, thanks. So David told you about some of the exciting things that are ongoing in HRS, including the testing all respondents for COVID antibodies currently in the field, currently under collection, and extended psychosocial questionnaires to be mailed to various bits of our sample, including, and we also plan maybe a standalone mailing questionnaire next year. What I'm going to be talking about is none of those exciting things. I'm gonna show some results of this COVID-19 survey module that we fielded on what's about a random quarter of our sample. Now this is phase 1 is a random quarter. Phase 2 is going to be another random quarter, but it's as David mentioned, this is still ongoing data collection. Response rate was about at 60% when we released this data. So it's about 3,000 people, and I'm gonna use survey weights to that mostly balances race and ethnicity and some state level variation that are not equal. So this graph shows just the histogram of the week of interview. Most of the interviews happened in second half of June and in July, and the date of the interview is not random, not randomly assigned. There's quite some variation in a lot of things across time. So I'm not going to show any across time comparisons, but whatever we'll see is representative of the summer of 2020, mostly July. Think of July. There's quite a lot even within that module, that approximately 10-minute long part of the questionnaire. And in this talk, I will focus on a few things, mostly those that you can analyze mostly from survey data. and you need actual people to give actual responses, and you cannot really substitute admin data for those. So some of that is concern, other that is income and spending. And if we get to the end of the talk, I'm going to show you some things that people tell us in their own words. So these are the concern and experience questions. One is there's an overall concern question, scale 1 to 10, and then there are various levels of experience of COVID, whether the respondent themselves had COVID or tested positive for COVID, whether somebody else in the household had COVID or was tested positive for COVID. And what we think is going to be very interesting is whether the respondent knows someone who had COVID or someone who had died from COVID. So these are the rates. The left side is by education groups, and the right side is by race and ethnicity. About 1.5% had COVID, reported to have had COVID in the sample. That's not much interest heterogeneity there. COVID in the household is now combined the respondents and their households. That's about twice the rate, but again, not significant differences. Where we see significant differences is whether whether the respondent knows someone who had COVID, and there's a very steep education gradient that's probably due to the size of networks people have. The more people you know, the more likely somebody from that group had COVID. On the other hand, if you break this down by race and ethnicity, you see that African Americans have an especially high rate of knowing someone who died from COVID. And I also ran some regressions. And this is people's response to concern. Average concern is pretty high on a 1 to 10 scale. It's about 8. Standard deviation is about 2.5. There's not much going on by education. The right panel shows something else. This is the proportion of people who are not at all concerned. That's only 5% in the sample, but among white non-Hispanic males, that's closer to 10%, but sample sizes are small. So here are some regressions. I'm going to come back to the results, but there's one picture that I think is kind of interesting. This is the gender difference in average concern by gender and whether single or in couple. And so the overall average is something like 7.5, and the single women are the top and darkest line. It's a flat line across age. Single men are the bottom green line, and the difference is pretty wide. It's about 3/4 of a standard deviation. And the difference starts closing after age 65 and closes by age 80. By age 80, there are no differences in terms of concern across gender or whether in a couple, and that's kind of true for other demographic characteristics as well. We had questions about foregone and deferred healthcare. We saw a presentation harnessing admin data for that. What we have now is survey responses. And these questions explicitly ask for delayed or not getting the care at all. And these are the categories by groups of education: major surgery, outpatient surgery, prescription drug, very low rates of foregone or delayed care. Now, doctors visit for new condition, and doctors visit for ongoing condition or for screening or medical checkup have a higher rate. And there is kind of an increasing education gradient, but it's by far the strongest for dental checkups. I mean, I think the reasons are kind of obvious. There's a lot of, we also ask why the respondents thought these were these types of care were delayed or foregone, and by far the most important is rescheduling by doctors and hospitals. There are questions of COVID on work, and here it's a stack bar chart on the left side. Among people with 0 to 11 years of education, almost half stopped working. Most of them were furloughed. The second most important category is other reason, as opposed to quit or lost, and that is it's under progress to make sense of what other is. And if you look at people who continued working but their work changed, that's the right side picture. What we see is hours changed for the lowest educated people, and working from home, that's for people like us, college educated people, not for others. Effect on income, expenditures, and hardship. I would like to focus on just income and spending. And income up or down, relatively low rates of income going down, and relatively little about education, as opposed to what we see in terms of spending on the right-hand side here. I mean, there's a steep increasing gradient of decreased spending. That was okay. So spending is negatively related to education. The more educated cut spending the most, and that's true if you condition on other things as well. And it's especially so if you look at decreased income, Hispanics stand out, even if you condition on education and age. And of course, income decreased more for people at the lower age group in our sample who still work. Whereas in terms of spending, it's the most educated who cut back spending by far the most, and of course the youngest, for kind of, I think, reasons that are not very surprising. So two more things. I think this data is going to be eventually valuable to see kind of effects of COVID on staff. And in terms of staff, I show results with from regressions with three different left-hand side variables that are survey measures of health, self-rated health. It's the way it's going to show in the regression is standardized, and higher values are going to mean better health. Depression, it's again going to be standardized here. Higher values, more depressed. And a subjective probability to living to a target age on a scale of 1 to 100, people are asked what the chances that they're going to live to a target age. I converted that to a 0 to 1 probability. On the right-hand side, there are these COVID module variables in the HRS. And we further condition on the 2018 values of all of these three outcome variables. So they're going to be on the right-hand side, and demographics. And yellow, so these are the results from the first set of regressions, in which the right-hand side variables are concern and experience with COVID and deferred or delayed healthcare. And yellow are the coefficients that are statistically significantly different from 0 when conditioned on everything. And we see that self-rated health is actually negatively associated with deferred doctor's visit. Deferred dental is probably is just selection, and that's what we kind of see in the subjective probabilities case as well. But deferred doctor visit is negatively associated both with self-rated health and depression. Yet, perhaps surprisingly, neither our concern measures nor other exposure to COVID measures seem to be related to depression. And if you look at work and so economic variables, how they are associated with self-rated health, depression, or the subjective survival probability. This other reason to stop working as an interesting category is probably voluntary separations. They're associated with higher self-rated health, and we don't see anything with respect to working from home, for example. I mean, there's a lot of selection. There's a lot of selection going on. There's something that we see about help received. Non-monetary help received is associated with worse health and higher levels of depression. Probably it's again probably reverse causality. So I think this data has a lot of potential for the future, especially when combined with the rest of the panel and when we're looking at longer term outcomes. And of course, all of this data can be combined with linked with CMS data or social security data in a secure environment. And of course, state level policy changes can be linked to the data as well, again in a secure data environment. So I think there's a lot more to learn from this data than what I have just showed, and maybe this particular module of COVID-related questions is not going to be the most valuable part of such analysis. But there are some interesting things here that I think are not you would not be able to see otherwise. And one is these results about knowing somebody who had COVID and knowing somebody who died from COVID. I mean, close to 40% know someone who had COVID, and close to 20% know someone who died from COVID in our sample. And this is summer. This is the summer. And so that's going to increase probably a lot for the fall wave. And level of concern is high. There's a small minority that is not concerned. And there are some very interesting patterns by not only by race and education that people would guess, but also by whether people are single, and it's a single white man have lower average concern than below age 70 have lower concern than anybody else. And then another interesting result is that spending decreased more than, so more people report that their spending decreased than the proportion of people who report their income decreased. There's not much of an education gradient for decreased income, but there is a remarkable result for Hispanics, and spending decreased for the younger and more educated part of our sample. And there are the associations with current health, and there are some interesting positive as well as interesting negative results. I mean, by that I mean no results. These are very preliminary results, so I don't want to spend too much time on them. Just closing with just a taster of what people told us. About half of our respondents are providing some answer to the following question: are there other things about your experience since the coronavirus pandemic started that you would like to share with us at the end of the interview? We are in the process of transcribing those. So 50% say something. Of those 50%, 20% are transcribed now. So that's about 10% of the 3,000 people that we have in this sample, but it's work in progress. There are some very interesting ones. Some responses that you think are, closer to an average response, but you also have the, and so there's actually if our linkage is correct, which is not 100% sure, this second bullet point is from a married woman of age 76 with a college graduate degree and reporting a pretty high concern, who thinks this is a hoax. By the way, the concern is about the whole situation, not the disease itself. So that's not necessarily an error here, but something interesting. And somebody with a proxy respondent and a dark child for her mother who's in a nursing home. So I think this text might also provide some good opportunities to mine in the future. That was it so far. Thanks a lot.
Thank you. So there were a couple of questions about how this compares to other data. And David Weir said you'll be able to compare them to other surveys when you can get their data. I don't know if you want to add anything on that.
Well, I mean the slide David showed about so this is a summer, so experience of COVID is still kind of not as frequent as now, but we have a remarkably good match of the geographic and time variation of COVID experienced and the admin sources. And we also have some other results like the effect of the stimulus payment program. And what we see that we haven't presented anything on that here. That matches quite well with other source of other surveys that you know. One thing that I have to emphasize is that everybody was improvising when putting together this questionnaire. So there was less harmonization across surveys than ideal, because everybody wanted to get out quickly. So it's gonna take more work than usual to compare things across surveys, I think. But we of course will do what we can.
Let me ask you if there are a bunch of comments. Let me ask you if there are particular issues in the chat that any of the members of the team want to address.
I have not followed the chat, but I will take a look.
Bruce, do you want to ask your question?
Sure. No, I was just wondering if you could look at how mental and physical health vary according to the case rates in different, I mean, I don't know what level of geography you have. Presumably you have a fair amount of detail. I don't know whether you can use it for, to what extent you can use it for research purposes, but across geographies, case levels, and the various policies that that folks are experiencing.
Oh, absolutely.
Before you take that one, Sylvia had a sort of similar theme, which is how does it compare pre and post COVID? So I don't know if you know about either of those dimensions, geographically or time series.
Well, I mean, all of our, so the publicly available data is not very detailed in terms of geography, but there's access to pretty detailed geographic information in our secure data environment, which you can work with from home as well. And there, I mean, we're trying to put in data sets that will describe state level policies and maybe other variables, but every researcher can bring their own geographic data and link it to the HRS. But this is a panel, so you can also condition on individual level pre-pandemic things, like in the last set of regressions, we conditioned on pre-pandemic outcome levels of all the outcome variables, which is a big plus of panels such as like the HRS.
So I would just emphasize, I mean, the data are out there. You can look yourselves. So we looked a little bit at time series changes at the individual level. Basically, for the older population, at least those who are willing to do a survey in this environment, we don't see big changes in depression measures. Maybe more fine grain or more subtle measures will show a little bit more, but other studies find the same thing. There's bigger effects on younger people than there are on older people. Even though older people are much more vulnerable biologically to the disease, they seem more able mentally to handle the situation.
Okay, thank you all. Very nice paper. Very good job. Why don't we move on to Jave Grooms, Alberto Ortega, Joaquin Rubal Calva, I hope I got that right, on racial and ethnic disparities, essential workers, mental health in the COVID pandemic.
Thank you so much. Thank you all in advance for your comments and your feedback. This paper, Racial and Ethnic Disparities, Essential Workers, Mental Health in the Coronavirus Pandemic, was something Alberto, Joaquin, and I started to think about very early on in the coronavirus. We were collaborating on something else. And we began having dialogue about how vulnerable populations may be disproportionately affected by COVID. And so we started to investigate or started to brainstorm on how we could look at this. And we became part of a survey group, which Ed Vargas is part of. Okay. So I'll go a little bit on background. I'll spend most of the time on the data and methods. We use a unique survey data, nationally representative, to look at mental health distress and go over the results and get in a little bit to what we hope to do in the future. So as many of us are aware of, as of today, there are 276 deaths in the United States from COVID, 14 million confirmed cases in the US. January 21st marked the first reported case in the US, and about a month later on February 29th was the first reported death. There was a national emergency declared on March 13th, and by the end of March, 30 states had stay-at-home orders. The survey, we have multiple waves in our survey. The survey wave we're gonna focus on is right towards the end of March when the survey was fielded at the very beginning of April. So we were really interested in looking at how COVID has affected American households beyond exposure, beyond mortality. And as coronavirus, as we went into March and April, it became pretty clear that Black communities were being disproportionately affected. Right, so here's a snapshot. When we look at the population, the Black population in Louisiana, it's roughly 32% of the state population are African American. Yet in April, as of April 6th, 70% of the COVID-related deaths were identified as Black through the CDC. And we see Illinois and Michigan relatively close, about 14% to 15% of the state's population is Black, but about 40 to 42% were counted as Black deaths for COVID, right? Individuals that passed away from COVID were identified as Black. And Carolina was pretty representative at 22% of the population in North Carolina identified as Black and roughly 22% of the COVID-related deaths. But to give you a sense of what was happening in the United States on April 15th, because this is in the middle of when we fielded our survey. So of the states that collected information on race and ethnicity, below are the number of states which reported an overrepresentation, so more deaths, more COVID-related deaths than the state's population of that race or ethnicity. So for individuals that identified as Asian, it was one of 19 states, and I believe it was Alabama. For individuals that were identified as Black, it was for 18 of 23 states. Hispanic, 0 of 20 states. One thing to note for Hispanic and Indigenous is while they weren't overrepresented for COVID-related deaths, they were overrepresented for COVID-related cases at this time. Indigenous, it was 1 of 12 states. I believe that was New Mexico. And for individuals that were identified as white that passed away from COVID, it was 0 of 23 states that were overrepresented. Now, just getting a snapshot of what was happening. So this is the end of June or end of July, and this is looking at COVID-related deaths per 100,000. And we can see that those individuals that were Black or African American substantially at greater risk of passing away from COVID-19 relative to the rest of the other racial and ethnic groups in the United States. You can see Native Indigenous people and Hispanic were 40 COVID-related deaths per 100,000. And then Asian, white, Native Hawaiian, and Pacific Islanders and other were right around 30 COVID-related deaths per 100,000. So it became really clear to us that there was a disparity in cases and in mortality as related to COVID. What we really were interested in is, okay, we know more people are dying from COVID that are Black, that are Hispanic, but what are the other outcomes? How else are they affecting these vulnerable households? So a motivating force behind this research is, as the US charts a path forward, how would it incorporate policies that ensure racial and ethnic equality as part of the recovery without understanding how COVID-19 has impacted Black and Hispanic communities beyond viral exposure and mortality? And we focus on Black and Hispanic communities for a few reasons. One, our survey, we don't have enough observations to look at Indigenous people, Pacific Islanders, or individuals that identify as Asian. And two, we were also, in this paper, we also exploit this idea of whether you're an essential worker or not. And we know that Black and Hispanic workers are more likely to be frontline workers, essential non-healthcare workers. So what are we interested in? So given this racial and ethnic disparity of COVID-19 cases, mortality, and exposure, we use a nationally representative survey to assess how reported mental health distress differ by race and ethnicity and across current employment status. So in our survey, we asked questions about whether individuals are working from home or not, and if they're considered an essential worker, and if they are, if they work in the healthcare industry or not. And these are all self-reported. So getting into the data. So we use the National Panel Study of COVID-19. The data we utilize has been collected as part of a larger survey fielded by UCLA in collaboration with University of New Mexico, Arizona State, and UNC Chapel Hill. So it's really great. This panel study started right before the pandemic was declared a national emergency, and on March 11th was when it was first fielded. But the first wave didn't ask the economic questions and the mental health questions and the financial stability questions that were asked in wave two. So in wave two, Alberto, Joaquim, and I were lucky to become part of the study, and we were able to introduce economic questions, mental health questions, financial stability questions, as well as some education questions. We have wave three as well. We don't utilize that in this study, but we are hopeful to utilize it in the future. And we look at it for some other research we're working on related to COVID. And we are in the process of working on wave four and hopefully fielding wave five as well. So wave two. So wave two, we have a little bit over 3,300 observations, and roughly about 2,000 of them are a panel. They're from wave one, and roughly 1,000 is a fresh cross-section. Each time we go back into the field, we introduce a fresh cross-section. This is it's a national household survey. We have data down to the zip code. Our racial breakdown is roughly 70% white, 70% of respondents are white, a little bit less than 10% are Hispanic, and a little bit more than 12% are Black. And it's these economic and health questions that were introduced in wave two that we're really gonna focus on for this paper. So for our survey questions for employment, we have information about whether you are unemployed, and if you were unemployed, were you in the labor force or not? Were you actively looking for work? We have questions of whether you're an employed non-essential worker, and if so, are you working from home, right? So when we talk about employed non-essential worker in this paper, we are strictly talking about those individuals that are still working, but are working from home. And just reminder that we're looking at the first few weeks of April. This was still pretty early on during COVID. And then we ask questions about if you're working and you're not working from home, are you in the healthcare industry or not? And so employment 3, 4, and 5 is really what we're gonna focus on in this paper, looking at mental health distress across race, but also across worker typology. And we have other variables about financial benefit, about financials. We have unemployment insurance benefits, stimulus. One of the really interesting questions, and my colleague Joaquim Rubalcaba is on here to help answer questions later, but I believe he's the one that thought of this idea of this question. We asked questions about when did you apply for unemployment insurance and when did you actually receive it? So we have information about how long it took to receive it, and we see some differences across race on length it took to receive. We have questions about stimulus. What were you spending your stimulus on? If you haven't received it, what do you predict yourself to spend your stimulus on? Household income, do you live paycheck to paycheck? We have other questions on physical health, eating habits, right? Substance use. We have questions on distance learning. We have household level questions that look at age, size, composition of the household. how many children live in the household, how many elderly live in the household. But for this paper, what we really focus on is this mental health. So we use a quasi PHQ-9 and a quasi GAD-7. We take 3 inventories from the PHQ-9 that get at depression and 2 inventories from the GAD-7 that get at anxiety. Unfortunately, we just didn't have the bandwidth in this survey to ask all of these 16 inventories. So we focused on those that we felt got really at depression and really focused on anxiety. And this is what we've seen other studies do as well. So what exactly mental health questions did we ask? So for anxiety, we asked, so in the past 2 weeks, how often have you been bothered by the following problems? Anxiety, feeling nervous, anxious, or on edge. 2, not being able to stop or control worrying. And then when we're looking at depression, it's little interest or pleasure in doing things, feeling down, depressed, or hopeless, and trouble sleeping at night. And respondents, each of the mental health items were surveyed using a 4-point scale, right? So not at all, several days, more than half the days, and nearly every day. So wrap back, there's a few limitations to the paper as it is now. It is a descriptive paper, right? We use descriptive analysis, it is not causal. While we're hopeful to get at some mechanisms in our future research, this paper as it is today is descriptive. There might be selection bias in terms of the employee type represented. So we weight the data to, similar to what's done in Burfish, to resemble nationally what is happening. One big caveat is we don't have baseline analysis, right? We didn't have the wherewithal to think in February or January to put this survey out. So what we do, and in our paper, we describe this a little bit more, is we look at Burfish and we look at what was happening in the response to PHQ-9 and GAD-7 in Burfish in 2018. Also, another limitation is our worker typology is self-reported. So there's no way to cross-reference this. We didn't, and I don't know that we would have asked what their current industry they work in or what their job title is. Okay, so this is what we superimposed our results up against what Burfish results were for 2018. And so Burfish was in the red, ours is in the blue. And what we see is that across white, Hispanic, and Black, on average, we see elevated levels of depression and elevated levels of anxiety. And we feel pretty comfortable that that's what we expected to see, that across the board, everyone was going to report elevated levels of depression and anxiety. We see some differences across race, but nothing too glaring. So how does reported mental health distress differ by race, ethnicity, and across employment status? So a preview of results, and then I'll get a little bit more in depth, but we observe a statistically significant difference in the mental health distress of Black and Hispanic respondents in some of the worker typologies relative to white counterparts. Results suggest elevated mental health distress for all Black workers, but particularly essential non-healthcare workers, and for Hispanic essential non-healthcare workers. And this follows what our intuition was, that essential non-healthcare workers are typically lower paid workers, frontline industries, have higher level of exposure. So to get at this, we use 2 models. So to assess mental health distress across race, ethnicity, and worker typology, we employ 2 models. The first, we estimate the probability of experiencing mental health distress across each individual inventory, so across all 5 individual inventories. And then we estimate the severity of mental health distress from the quasi-GAD-7 and PHQ-9 scores. And so there we generate a score similar to what's done in Burfish. So using a logistic regression, our dependent variable is a dichotomous variable, 1 if there's any worry in the past 2 weeks, and 0 if no worry is reported. Our variable of interest is that intersection between the employment indicator and the race binary. And we control for state fixed effects. We have a vector of state level pandemic response policies. And we have a vector of individual level characteristics as well as household characteristics. And then for a second model, we transform our measures of severity using the Z-score. This approach allows us to interpret intergroup differences of symptom severity in terms of standard deviations. And so our dependent variable here would just be this quasi-GAD-7 and PHQ-9 score. Again, it's quasi because we, for GAD-7, only use 2 inventories instead of the full 7. And for PHQ-9, we use 3 instead of the full 9. So let me kind of in terms say what we find, our results find. So for these essential non-healthcare workers, for individuals that were Black, we find a statistically significant increase in elevated, so we find statistically significant elevated levels of mental health distress across all 5 inventories, ranging from 27 to 52 percentage points. For those that were Hispanic, we find statistically significant elevated levels of mental distress across inventories ranging from 33 to 62 percentage points. We do find some statistically significant differences for essential healthcare workers, although I caution these results because when we cut across, we only have, I believe, roughly around 200 essential healthcare workers in our data set for the entire study. When you start cutting across race, you get to such a small group. One of the interesting results that we weren't expecting to find is non-essential workers, so workers who are working from home. Those individuals that were Black reported elevated levels of mental health distress for 3 of the 5 inventories. And so to give you a sense, the green are the essential non-healthcare workers. So we can see for anxiety, worry, depression, lack of pleasure, and lack of sleep, we can see all statistically significant increases. Keep an eye on time. Okay, so for our next model, what we did, So for our next model is the scores. So what we see here is we instead of looking at each individual inventory for the depression and for anxiety, we created a score. And we see similar results for individuals for essential non-healthcare workers. We see between 0.7 and 0.8 standard deviations for elevated levels of depression and anxiety. And for Hispanics, we see nearly across the board 1 standard deviation, right? We see elevated mental health distress of 1.1 standard deviations for depression and about 0.9 for anxiety. So we limited, our results are robust to limiting our data to those individuals under 65. It's across multiple measures of anxiety and depression, including and excluding the 5 states with no stay-at-home order, and control for perception of COVID-19 exposure. So we asked questions similarly to the previous presentation, whether individuals knew someone that passed away from COVID, whether they were exposed to COVID. So we were able to get at a sense of perception of COVID exposure. So in conclusion, across all inventories, essential non-healthcare Black and Hispanic workers have elevated levels of mental health distress. We believe this presents strong evidence that Black and Hispanic workers face different mental health stressors than their white counterparts in the same employment type. This is especially important given Black and Hispanic workers are overrepresented in jobs, frontline industries with relatively low wages and often no employer-provided health insurance. One of the questions we asked on our survey was about health insurance, and we do see a difference. So looking at essential non-healthcare workers, it was roughly individuals identified as white, roughly 2% of essential non-healthcare workers lack health insurance, roughly 8% of Hispanics lack health insurance, and 10% of those individuals identified as Black lack health insurance, right? So between 8 to 10% of Black and Hispanic essential workers working through the pandemic very early on in April lacked health insurance. So moving forward, it's essential to ensure that the pre-existing barriers in seeking mental health treatment do not further exacerbate the prevailing disparities in diagnoses and treatment of mental illness. Interventions to help combat a looming mental health crisis might focus on meeting people where they are to help provide adequate mental health care. And I think it's important to note that the co-occurrence of mental health and substance use, there's a lot of possible looming other side effects of these elevated levels of mental health distress. Thank you. I welcome questions. My co-authors are here also to hopefully help answer some questions.
Thank you. That was a very interesting and extremely well presented. Ellen Mira had asked a question. She told me she had to run off to something, but she asked the question, given how much higher COVID mortality is for Blacks, are you surprised by these findings? Or is there a way to kind of benchmark them? Like, man, this is really big, or I'm surprised it's not bigger, or, you know, like how do I interpret the magnitude of them?
That's a good question. Sorry, I'm reading the question as well. So I think, you know, we control for exposure. One thing I would like to go back and look at, a comment I got just a couple of days ago on presenting this work, is if we stratify by perceived exposure, how might these look different, right? We're stratifying by race, but also by employment type. But what might it look like if we stratify by exposure? Joaquin, did you want to add anything to that?
I remember looking at the results initially, and I was actually surprised that we didn't see a larger disparity than what we saw given our results. And so we really looked at the literature on resiliency across race and ethnicity to see if there was any evidence there, and we got a lot of mixed results. And so yeah, I'm not really sure why you know, we weren't getting larger disparities than what we had thought.
But to add on to that, one thing that was about financial and employment situation, or because I'm worried about. So I do think that may be contributing to our results that we see for non-essential Black workers, right? So for non-essential Black workers, we still see anxiety and worry. And I don't remember who we cited in our paper, but right, there's like a saying that Black men are the last to be hired, first to be fired. So I do think that some of this worry of employment could be contributing to this mental health distress. Something we're hoping to do, so we have this information for wave 3 as well. Something we're hoping to do as time goes along is better understand the mechanisms that are causing this. We thought it was really important in real time to expose what's happening to show these associations while we continue to work to better understand the mechanisms causing these associations.
Could you, sorry to jump in, I'm trying to think about sort of the variance of, you know, how much of the worry is about disease versus jobs. And you said you had zip code, right?
Mm-hmm.
So I mean, I realize you sort of have vanishingly small sample sizes, but I'm wondering, have you looked at that even sort of like, you know, median, below median, high, above median, or something along those lines?
So I think that's something we're still working on. So what we had done for the first pass is look at perceived exposure and control for perceived exposure. But, you know, we're talking about going back and trying to figure out some way to characterize actual exposure, since we do have zip code data. So I agree. I think that could be really useful in understanding if it's COVID. Something also to note is this survey was filled in April. So this was before George Floyd passed away. This was before a big push for Black Lives Matter movement. We do have wave 3, which was after that. So seeing those differences could be really interesting as well.
We also asked a lot of questions about people's perception around George Floyd as well, and the national response to that. So we can control for a lot of that as well.
I'm looking through the questions. You know, one question we've got in the past is using Versus as a baseline. One of the issues we have with this paper is any previous studies that look at mental health distress don't typically have information on the employment type. So being able to control for race and employment type pre-COVID becomes pretty difficult. And so that's what we're still working on, finding a way to look at some causal inference of COVID across worker typology and race, but that is a little bit more difficult, we're finding.
Let me just open it up to either any of the chat questions that you want to address or any questions that other people have. Just feel free to raise them. You may want to stop sharing just so you can see everyone. There you go. Thank you. I think it would be interesting to compare these to things like the HRS and other data sources, the household pulse survey and things like that as well.
One thing, Lisa, we created this survey and then the pulse survey came out. One of the reassuring things was I believe the pulse survey also uses 2 inventories from the GAD-7 and 2 inventories for PHQ-9 to get at this level of depression and anxiety too, which was reassuring for us.
Okay.
So that's a really good suggestion. One person asked if we can use a benchmark the differential responses across race from other surveys pre-COVID. And we hadn't done that, but we could do that, right? We could do that looking at versus.
Yeah.
Good suggestion. Thank you so much.
Thank you very much. Thank you. That was terrific. Okay. And then our final paper is going to be Larry Baker, Kate Bundorf, and Maya Rossin-Slater on racial and ethnic disparities in primary care use in the COVID-19 pandemic.
Okay. I'm sharing my screen here, so hopefully you all can see this. Okay, great. Thank you so much for including us on this very interesting program. And thank you to all of you for being here and just sticking it out till the last session. So this is joint work with my colleagues, Lauren Baker and Kate Bundorf at Stanford. This work wouldn't be possible without fantastic research assistance from our pre-doctoral research fellows, Christine Kim and Kate Moulton. So we're looking at racial and ethnic disparities in primary care use and the COVID-19 pandemic, of course. So just to sort of motivate this work, you know, as everybody on this conference knows, there exist large and persistent racial and ethnic disparities in access to primary health care and use. So broadly speaking, Black and Hispanic patients face higher barriers to receiving adequate and timely care than their non-Hispanic white counterparts. Now, while the evidence on the impact of primary or preventative care on sort of health outcomes as well as healthcare spending is of course varied and mixed, you know, broadly speaking, we think that timely primary care is important and therefore, you know, disparities in care might contribute to disparities in health outcomes. So as we all know, COVID-19 has created unprecedented challenges for the healthcare system, but there's relatively little known about how these disparities specifically evolved during the pandemic. You know, we've already seen today quite a lot of work on various aspects, both in terms of the impacts of COVID on outpatient and primary care use, such as the paper presented earlier today by NGZ Dan and co-authors. And then of course, also we know a lot about, we're starting to know a lot about the disparate impacts of the pandemic across different races and ethnicities in terms of actual infections, caseloads and deaths. And then just now we learn more about mental well-being. But it seems that we still don't know quite as much about disparities in access to care. So just to sort of bring us all on the same page, you know, what we know so far about COVID-19 and primary care use based on the ever-evolving and quickly expanding literature. So of course, we know that federal, state, and local regulations have meant that many healthcare providers have had to either limit or completely stop normal operations. And of course, individuals have also changed their behavior, both because they're concerned about getting exposed to the virus, but then also because they are many people are losing their jobs, and with that, they're losing their employer-provided health insurance. So just one data point on this, a nationally representative survey of non-elderly adults conducted in May of 2020 shows that almost half of adults in families who have lost work-related income are forgoing healthcare they would have otherwise gotten. So again, so we know, unsurprisingly, there's a large reduction in outpatient primary care use that's been documented using various data sources. So one sort of thing I think would be interesting to try to understand is what's driving some of the differences and the magnitudes across, that work. And what we'll be showing you here today. Of course, different data means different clinics, for example, are reporting in those data from different areas. Also different just methodologies and different timelines. But, so I think going forward, it will be useful to try to understand more about kind of how to compare across these different studies. And we also know that, this reduction is not the same for all types of care. So for instance, there's actually less reduction in access to mental health care, as well as some evidence of urgent care, in part due to more use of telehealth. And then, there's this question of, is this mostly driven by policies like stay-at-home orders, or is this mostly driven by individual behavior? Our read of the literature is that, it suggests that most of this is driven actually by individual behavior rather than policies per se. Now, when it comes to racial and ethnic disparities in the COVID-19 pandemic, as we've discussed in the last few talks, Black and Hispanic individuals are both more likely to contract the virus, as well as more likely to die from it than non-Hispanic whites, although of course there's some important differences across geography and across those two subgroups. But what about disparities in care utilization for those who have not contracted the virus? So one question is whether minorities bear a disproportionate cost of the pandemic on this margin as well. And then digging into that, of course, there's all kinds of differences within those groups. So for instance, are there differences between patients of different ages, like children versus prime age adults versus those who are over 65? So one paper by Whaley et al. Do a little bit of analysis by race ethnicity using information on zip codes. So in looking at the composition, the racial and ethnic composition of patients' zip codes, finding that those in zip codes that have a higher proportion of racial and ethnic minorities actually experienced smaller reductions in outpatient visits in March and April of 2020. But that study did not have access to individual level race ethnicity data. And more generally, we know less about other racial groups, so Asians, American Indians, Indigenous people, largely in part due to sample size constraints. So what we're going to do in this paper is we're going to use novel, large-scale, real-time, so to speak, although there is some lag, data from more than 1,000 family medicine practices in the United States to answer the following 4 questions. So first, how did primary care use change in the first few months of the pandemic relative to prior years? And then what were the differences in primary care use across 5 racial ethnic groups before and then during the pandemic? So we're going to look separately at Hispanics, non-Hispanic Black, non-Hispanic White, non-Hispanic Asian, and non-Hispanic American Indian, Alaska Native. Are these baseline disparities and pandemic-related changes and disparities different across patients of different ages? Again, we're going to focus on children under 18, prime age adults 18 to 64, and then individuals age 65 and older. And then lastly, are these baseline disparities as well as the pandemic-related changes and disparities different across different types of visits? So for now, we're going to specifically look at visits that are seen that are preventive, as coded as being preventative, visits that have any vaccine associated with them. These could be also coded as preventive, or they're just for the vaccine, and then all other, i.e. non-preventive and non-vaccine related visits. So our data is the PRIME registry. So this is a qualified clinical data registry certified by Centers for Medicaid and Medicare. We have electronic medical record information on healthcare delivered by over 1,200 family medicine practices, in total about 5.8 million patients who have been seen since 2015. And we're still, this is a huge data set. It's fairly new, and we're still working out all the details of all the variables that we have. But for now, we have information on patient race, ethnicity, age, gender, health insurance status, although I will caveat that it looks like this information is actually not super reliably coded, and then diagnosis as well as CPT codes. So the way that we conduct our analysis is going to be a little bit different than what has been done in prior work, in which folks have typically just sort of aggregated the total number of outpatient or primary care visits of different types and sort of looked at trends over time. Here, because we're interested in trying to look at disparities by race, ethnicity, by age, by type of visit, we want to be careful in terms of accounting sort of for pre-existent differences in access to care in years prior to the pandemic. So what we do to do this is we're going to focus on sort of 4 cohorts of patients where we define our cohorts by those who had at least 1 visit in 2016. And the second cohort is patients who had at least 1 visit in 2017. Then those who had at least 1 visit in 2018, and those who had at least 1 visit in 2019. Okay, so these are patients essentially who have some contact with the clinics that are in our data. And then what we're going to look at is what happens to their likelihood of returning for another visit in the following year, specifically in each week of the following year. In order to make sure, because this data is relatively new and there's some variation in which practices report in different years of the data, in order to make sure that our results are not being driven sort of by practices that are dropping out and so on, and maybe those practices are located systematically in places that have different racial or ethnicity compositions, in order to sort of avoid issues along those lines, we're going to limit our analysis to a consistent set of practices that are reporting data in each February of 2016 through 2020, right? So we're focusing on February because that's sort of the last month pre-pandemic. And so we're kind of looking at the practices that have been in the data every February of every year, and looking at what happens to patients of those practices. As I mentioned, we're going to look at patients' return visits in each week of the following year. Right now, we have cleaned up data through week 21. That is the week of May 18th, 2020. But we were getting updated data every few months or so. So we're hoping to be able to extend this analysis further out. We're going to look at 5 racial ethnic groups, as I mentioned, for 3 different age groups and for 3 types of visits. Just to give you a sense of where our data is coming from, this is just a map of the locations of patients that are included in the PRIME registry. I'm not going to try to spend too much time on this, other than just to point out that our data is fairly broadly national, with counties all across America having patients in this data. Okay, so just to give you a sense of the characteristics of our cohorts. So here in the top panel, we just have some baseline patient characteristics. Mean age is around 47, 48. About 43 to 44% of our sample is male. And then you see the racial and ethnic distribution here down below. One thing I just want to highlight here is that it's helpful for us that the composition of the 4 cohorts that we're studying is quite similar, right? So it's not the case that the patterns that we're going to be finding for 2020 return visits are going to be biased by the fact that the types of patients who are in the 2019 cohort are sort of systematically different from patients in earlier cohorts. That does not appear to be the case, which we wouldn't have necessarily thought would be the case, but it's reassuring to see. And then in the bottom panel here, we're showing you some of the kind of the outcome variables that we'll be looking at. So here we're reporting the share of these cohorts that have at least 1 preventive visit, vaccine-related visit, or other type of visit through week 21 of the next year. It's approximately mid-May of every year. So already you can see that for the 2019 cohort, right, that's the cohort that we'll be following in 2020. You see substantial reductions in all 3 categories of visits, although there are some differences in the magnitudes across the 3 types. Okay, so I think this graph, which just uses kind of raw data, highlights kind of what we're looking at, and also motivates some of the empirical models, fairly simple empirical models that we'll be running. So here, what I'm showing you is data from two of our cohorts. So the 2018 cohort, that's the last pre-pandemic cohort, and then the 2019 cohort, that's going to be our pandemic cohort, right? These are the patients whose visits we're tracking in 2020. Okay, and then the lines here are different colors. I'm sorry if you can't distinguish across all the colors because we're trying to plot it for all of the different racial and ethnic groups. The black line shows return visits for all groups. Okay, and then you see the different categories and the different colors below. And I guess the thing to note here is first, there is some, seasonal variation across weeks of the year in terms of the likelihood that patients are returning for subsequent visits. But there's a clear fall that happens around week 12 of 2020. And so that's going to be the week of March 16th, 2020. Of note is that the federal emergency declaration happened on March 13th, the Friday before that. And so a lot of stay-at-home orders were issued immediately after that. So you see there's a big decline in return visits immediately following that for the 2019 cohorts, but there's some differences in terms of the magnitude of this decline relative to the pre-pandemic levels across the racial and ethnic groups that we'll be examining in our analysis. And essentially what we're going to do is we're going to look at the difference in return visits following the pandemic for the 2019 cohort, right? And net out seasonal differences in return visits across weeks of the year using the prior cohorts. Okay. So then we can also look at differences in patterns for patients in different age groups. So some interesting things emerge here. So first of all, as you notice, our Y scale is scaled the same across the three graphs here to ease comparison of these magnitudes. So for kids, one thing that you can see here is that, first kids have somewhat lower likelihood of returning in the subsequent year for a follow-up visit, for example, relative to patients age 65 plus, which is perhaps not surprising, so pre-pandemic. And then it falls once the pandemic begins. And what's interesting, that any pre-existing racial and ethnic disparities, so the different color lines on this graph, basically disappear, right? Almost entirely. The only group that we see sort of being even lower than the other groups here is the non-Hispanic Asian children, for whom we see even lower rates of return visit following the pandemic. Okay, for the elderly, so those who are age 65 plus, you see sort of, first of all, baseline visit rates are higher, which is perhaps not too surprising. There's still a big drop, but the sort of disparities continue to exist following the pandemic. And, there are some sort of changes in the relative magnitudes across racial groups, meaning that some disparities are actually reduced that we're going to explore in our analysis. Okay. Another way of sort of looking at our data is to, as I mentioned previously, to try to account for sort of the typical seasonality that occurs in different weeks of the year in terms of return visits. And so what we're showing you here are coefficients and 95% confidence intervals on interactions between different week indicators, right? So week 1 through 21 of any given year, with an indicator for the 2019 cohort, which is the cohort for whom we're studying the pandemic return visits, okay? So a couple things to note here. First, these graphs are showing you that relative to the average return visit rate across all years in our data, 2020 return visit rates are lower already pre-pandemic, okay? You see that by looking at the coefficients for weeks 1 through 11, right, on these graphs, and they're lower than that horizontal red line, okay? But of course, there's a drop starting with week 12, that week of March 16th, 2020. But one thing that's sort of interesting is you see that there are differences in these magnitudes across racial and ethnic groups. So the fall for non-Hispanic whites, for example, is bigger than the fall for non-Hispanic Black patients, and is also bigger than the fall for non-Hispanic American Indian. The fall for Hispanic patient is approximately similar to non-Hispanic whites. Okay, so what we do in order to sort of quantify these differences a bit more concretely is we collapse our data into cohort by week of year by patient race, ethnicity, cells, and then we estimate regressions where we, as the outcomes, we look at the number of return visits of different types per 1,000 patients in each week of every year by patients of each race, ethnicity group, okay? And we regress that on an indicator for, being in pandemic times. So that's week 12, 2020, March 16, 2020 or later. And we include race dummies and full set of race by week interaction terms, as well as interactions between our race dummies and the pandemic indicator to look at differences across racial groups. And so that's what these results look like. So here we're looking at return visits per 1,000 patients across all age groups, aggregated together, split by any type of visit, and then preventive, vaccine related, or other. Okay, so the omitted category here is non-Hispanic white patients, and then you can see the bottom here. The interaction terms are showing you the differential effects for different racial and ethnic groups relative to the non-Hispanic white group. So what you can see is that sort of for the main effect of being in pandemic times, there's a large drop in visits, which is about 23 per 1,000 patients. That's quite high, right, relative to the dependent variable mean of 61 per 1,000 patients. But there's interesting differences across racial and ethnic groups. So for example, the magnitude of the fall in these visits for non-Hispanic Black patients is actually smaller than that for non-Hispanic white patients. So that disparity, so to speak, is actually lowered. And if you look at whether this is driven by preventive visits or other types of visits, it's entirely loading on other types of visits. So it's not that the disparity in preventive visits is being reduced. It's that one hypothesis is that non-Hispanic Black patients might have more kind of urgent care needs because of various underlying health conditions and other reasons. And so there's sort of less postponable care for that group. When we look at, for example, non-Hispanic Asian patients, the disparity is actually widened, right? So the reduction in these visits for that group is bigger than for non-Hispanic white. For Hispanic, actually the difference in the reduction is not statistically different than for non-Hispanic whites. Okay. Then we look separately across age groups. So this is what it looks for kids. As you saw from the raw graphs, basically there was a huge drop in visits for kids. Here we see that this sort of happened across the board for all categories, preventive, vaccine related, as well as other categories. And then you also saw sort of in the raw data graph that any disparities kind of really got compressed. And basically very few kids were returning to see primary care doctors once the pandemic started across all of the different racial and ethnic groups. And you see that here sort of by the fact that, for example, for non-Hispanic Black kids, there's no significant difference following the pandemic on the interaction term. Potentially there's a bit of an exacerbation in the disparity for preventive visits, and maybe a narrowing of disparity in vaccine-related visits. Okay, the pattern for adults age 18 to 64 is here in this table. So adults are kind of have actually the smallest in terms of magnitude reduction, in pandemic, in visits during the pandemic. Again, kind of across the board for preventive vaccine and other. And, you know, again, there's some differences across racial and ethnic groups. So some disparities are made bigger. So notably here for the non-Hispanic Asian group, whereas others are made smaller following the pandemic. But, you know, and you can see here that, you know, for Hispanic, for example, this is being driven by preventive and vaccine related visits. Okay, and then here's for the age 65 plus, you know, as before, I noted before, they have a much higher baseline rate of visits. And what's interesting actually here, sort of the pre-pandemic disparities, right? So the coefficients on the main effects of the race, ethnicities, dummies suggest that individuals from minority backgrounds actually have higher rates of visits, potentially due to higher rates of various chronic conditions, for example. And some of these disparities, so some of these disparities go in the other direction following the pandemic, okay? So for example, the fall for Hispanic patients following the pandemic is larger relative to non-Hispanic white. Okay, so what we've learned from this analysis so far is that, you know, consistent with other data, we find that primary care visits fall substantially, starting with the week of March 16, 2020. What's interesting in our analysis is we do not see much evidence of a rebound, at least through the end of our data currently, which is the week of May 18, 2020. That's different than what's been documented in some other studies. You know, there's a lot of reasons for that potentially. We have different data that's drawn from a different set of primary care clinics. We're using a different method, right? We're not just counting aggregate visits. We're looking at return visits of a set of cohort of patients who have some interaction with the clinics that we have. And then there's differences across racial and ethnic groups. So I have some back of the envelope numbers here. You know, I wouldn't pay too close attention to all of these numbers exactly because we're still working out our analysis. This is somewhat preliminary, but there's some evidence that some disparities have gotten smaller, right? So for example, the Black-white, American Indian white disparities are reduced following the pandemic, whereas the Asian white disparity has widened. But the important point here is that the reduction in disparities is not driven by preventive visits, but instead is driven by not preventive visits, so potentially urgent or non-avoidable visits. The widening of the disparities appears to be driven by both preventive and non-preventive visits. When we look separately by age groups, we find that the magnitude of the reduction in primary care visits in relative terms, relative to the baseline means, is the biggest for children. We see a more than 50% drop in visits across the board. The Black-white disparity in vaccine-related visits appears to fall, but widens for other types of preventive visits. We see a relatively smaller reduction in the number of visits for Asian children, and this is driven entirely by non-preventive vaccine-related visits. Relatively bigger reduction for Hispanic children, driven by both preventive and non-preventive visits, and relatively smaller reduction for American Indian children, driven by preventive visits. For those who are age 65 plus, in baseline years, as we've talked about, non-white patients have higher rates of non-preventive and vaccine visits. These fall by more, relatively more for Hispanic and Asian patients, by less for Black and American Indian patients. And then relative to non-Hispanic white patients, vaccine-related visits fall by less for Hispanic, Black, and American Indian patients, and by more for Asian patients. So this is just like a first crack at some of these questions. I think there's a lot more that could be done with this data. You know, what we've learned is that the COVID-19 pandemic has, of course, presented a huge disruption to the delivery of primary care. These impacts were not necessarily equally distributed across racial and ethnic groups, however, or across patients of different ages. So some questions that, you know, we thought about and you might be thinking about, could these impacts be driven by entire practices shutting down? So it's like entire practices shut down and those practices are concentrated in certain neighborhoods that have different racial and ethnic compositions. That appears to not be the case. So our results actually hold up if we restrict to practices that still existed, already in the middle of the pandemic, basically by April, May 2020. What about, are some of these differences driven by differences in underlying chronic conditions? I think that's potentially a really important question to look at. We could do that. We're still working on cleaning up the data to figure out how to account for chronic conditions. What about differential responses to state local regulations? So, there's been quite a lot of work trying to understand the impacts of the regulations and trying to tease out the impacts of the regulations from individual behavior. It may be the case that the impacts of these regulations are different across different subgroups. So that's also on the to-do list to look at these effects. So that's all I have. And thank you very much for your time.
Thank you. As one measure of the interest, there was a very lively chat that was going on. And I saw.
Yes, I'm sorry I didn't have a chance to look at the chat.
Let me just ask Kate Bundorf whether, because I know she was responding, is there anything that she wants to raise or have you discuss?
I don't think so. There were lots of good. They made a nice to-do list for us in the chat.
Yes, thank you.
They wanted us to look at televisits. They wanted us to look at COVID visits. They want us to look at cancer screening. They want us to look at types of chronic care visits, and those are all good ideas. Interested in doing. Oh, and I think Yuchu suggested we could look for the kind of drive-through visits that folks were talking about, and we'll definitely ask the data supplier to see whether that would be identifiable in the data set. Oh, here, I'll give this one to Maya. Do you expect these effects and disparities to be short-lived, or will they come back when things rebound?
Yeah, I think that's a really, really good question. I think, one of the motivation, I think, for looking at this, it's sort of interesting. Obviously, it's really interesting to try to, important to try to understand, the potentially disparate impact of this pandemic on different subgroups and try to understand, who's most vulnerable in a variety of ways to try to direct the resources as much as possible to those subgroups. But I think kind of like a broader big picture question in my mind is, there's obviously persistent large pre-existing disparities in access to care by race and ethnicity. The pandemic is this huge shock to the whole system, right? For everybody. Is it gonna reset something? Or is it gonna make it even worse? Right. And I think we'll only learn that, as we continue to look at the long-term trends and, to try to see what happens to these groups. I mean, it's sort of, I think for kids, for example, you see basically there were, meaningful gaps before the pandemic, and then they're just completely, go away once the pandemic hits. Obviously some of that is just like very few kids are going to see the doctor. Clearly, but what's going to happen going forward? I think that's an important question.
So speaking of the long-term impacts, how's that for a transition? John Skinner and I have a question that we want to raise to the group. And that is, so we originally thought we were going to have one half-day meeting or one couple-hour meeting on COVID topics and health economics. And so we sent out something in October, I think it was, asking for papers. And we got back so many that we decided we should have 2 half-day meetings because there were so many good ones. And now people seem like thoroughly energized even after the second half-day meeting. And there were still lots of papers that we were interested in hearing. So the question is, are people like too zoomed out to do any more of this? Do people want to have another half-day meeting sometime in the winter? What do people have a view at all? Let me ask you, since it's impossible to all say words at once, let me ask you just to put in the chat, if you would. I'd be up for more. I think we've probably had plenty. Let's look for other avenues, anything like that, anything you want to say. Yeah, Dean Willard, try. Yeah.
This may be publication bias, certainly. We're not seeing the null, but it looks pretty good. Yeah, I mean, it seems like, I mean, this is a fun working group, and I think half day, this sort of half day meetings sounds like a great idea. I think we could do is maybe in the early winter send out a notice and schedule something. You think, David, are you including European? Yeah, actually, did you say that Elsa is doing survey data too, David? Or
yes,
Share?
both Elsa and Share have done surveys.
Yeah, that would be great. And the other thing is to have sort of a session on data sources, because we've seen a lot of new data sources here, and I think that's going to be useful for people thinking about doing their own research. I know I've talked to Kosali quite a bit about all of the different data, the C3N or whatever, all of these kind of data sources that are becoming available. So sounds good.
Maybe we should have a little on data sources. Yeah.
Dean's involved too. Okay. Good.
Excellent. All right. So I think that provides excellent guidance for us. We'll try and start a little later. We had to move it a little earlier today, so because we know many people want to go to the healthcare meeting. So,
yep.
So for that reason.
Great.
All right. Well, thank you to everyone. Thank you to the paper. I'll leave myself out of it, but thanks to, I learned a lot from all the papers that I saw. So thank you all a ton.